Hello. A very good morning to all the delegates and esteemed persons in this hall. Today we start the 30th annual conference BJISGCON 2024 at Ranchi. This is an auspicious moment where in this complete 2 days we will be discussing a lot of details according to the excellence in the part of medical and surgical gastroenterology. For that, I request our organizing secretary, Dr. M.M. Prasad sir, to please come and welcome our delegates, and let's start this program. Thank you.
Good morning, everybody. I welcome all of you on behalf of this BJISGCON 2024, and I have tried my best to provide you the academic test, great academic test, and we have also arranged live workshop, and for the participation of PG, we have now started gastro quiz as well as the poster presentation, and we have tried our best to give you a lot of updated information what is happening in the world of gastroenterology. So let's enjoy this program and keep blessing us. Thank you.
Now I welcome the anchors, Dr. Ipshita and Dr. Neha. Please come on the stage and do the anchoring part.
Hello. Oh, puro hajar acha. Berdi. Sound.
A very warm good morning to one and all. This is Dr. Ipsha.
And this is Dr. Jha.
And we very cordially welcome you all to the 30th annual Gastroenterology Conference. I welcome all our delegates and our speakers. Without any further ado, since time is in essence here, I call upon stage our first speaker, Dr. Aniket Kumar sir. He is a practicing medical gastroenterologist currently posted in Medanta, Ranchi, and he will be speaking on the topic interpretation of liver function test. For the moderators of the session, I call upon stage Dr. Chandan Kumar sir, Dr. M.L. Prasad sir. For the as the chairperson of the session, I now call on stage Dr. Ashish Jha sir, Dr. P.K. Mandal sir, Dr. S.K. Jha sir.
We welcome all the moderators and chairmen on the dais. And hereby, we look forward to this interesting and eventful session. Thank you so much.
May I have the slides? Good morning, everyone. First of all, I want to thank BJISGCON organizing committee to give me this opportunity to speak. in this meeting. The topic of my presentation is interpretation of liver function test. So we will start with the basics of the gastroenterology or hepatology, that is the liver function test. Liver function test, actually it is a misnomer, we can say. It is actually the liver biochemical test, because it shows the interpretation of not only the liver functions, but also the hepatocellular injury also. So it should be liver biochemical test. These are the blood tests used to help diagnose and monitor liver disease or damage. These tests measure the level of certain enzymes and proteins in our blood, and some of these tests measure how well the liver is performing its normal functions of producing proteins and clearing bilirubin, that is the waste product. To study the liver function test, we have to know the functions of the liver. We can broadly categorize these into the synthetic functions, that is the synthesis of plasma proteins, cholesterol, triacylglycerol, or lipoproteins. Metabolic functions like the protein metabolism, glucose metabolism, ketogenesis, TCA cycles, production of ATP, detoxification and excretion of the ammonia to urea, excretion of bilirubin, cholesterol, drug metabolites. Hemostasis. Liver is responsible for the glucose hemostasis and blood glucose regulation. Liver storage functions, like it acts as a storage house of the vitamin A, D, K and B12. And plus, liver has the function of production of bile salts. What is the need of the LFT? First is the screening. LFT is used as they are non-invasive test, weight sensitive modality for liver dysfunction. It is used to know the pattern of the disease. They are helpful in recognizing pattern of various diseases. It is helpful in differentiating between acute viral hepatitis and various cholestatic disorders and chronic liver disease. As we know that in the viral hepatitis, first of all, SGPT and SGOT will rise and it will come down, and later on bilirubin starts rising and falling. So it will tell the pattern of the disease. Other is to assess the severity. They are helpful to assess the severity and predict the outcome of certain disease like primary biliary cirrhosis. And they're also helpful in follow-up after giving certain drugs. And they also can be used to see the response in autoimmune hepatitis. So the classification of LFT group 1 are the markers of liver dysfunction. These are the serum bilirubin, that is total and conjugated. In the urine, we can measure bile salts and urobilinogen, total protein, serum albumin, albumin globulin ratio, and prothrombin time. These are the markers of the liver dysfunction. Means there is defect in the function of the hepatocytes, maybe function of some enzymes or so on. Second is the marker of hepatocellular injury, that is AST and ALT. And the third and last one is the markers of cholestasis, that is alkaline phosphatase and gamma glutamyl transferase. So there are some limitations of LFT, like normal LFT values do not always indicate absence of liver disease, because liver has very large reserve capacity, and vice versa, asymptomatic patients may have abnormal LFT results. So the diagnosis should be based on the clinical suspicion. So first of all, we will come to the serum bilirubin. Bilirubin is the end product of heme degradation. It derived from the breakdown of senescent RBC by mononuclear phagocyte system, especially in the spleen, liver and bone marrow. It is the major pigment present in bile, and it is the orange color compound. It is highly soluble in cell membrane and is very toxic. Therefore, its excretion in bile is one of the very important functions of the liver. Classification of bilirubin into direct and indirect is based on the original Vandenberg methods. We'll see the metabolism. Bilirubin is an excretory product formed by the heme part of the hemoglobin, and porphyrin part of heme are converted to bilirubin by the reticuloendothelial cells of the liver, spleen or bone marrow. Unconjugated bilirubin is bound to serum albumin and transferred to liver, where it is conjugated to glucuronate by UDP gluconyl transferase, and the conjugated bilirubin excreted in the bile, and the fraction of bilirubin from the stool is reabsorbed back to the blood via portal circulation, that is intrahepatic circulation. RBC, it is just the pictorial presentation of the same thing. RBC breakdown, it converts hemoglobin to heme, and heme is converted to biliverdin by heme oxygenase, and then biliverdin reductase convert it to bilirubin. In the gut, however, bacteria deconjugate back to bilirubin and convert to highly soluble colorless compound called urobilinogen. Only 20% of the urobilinogen are absorbed by the small intestine, and 70% of the urobilinogen can be oxidized in the large intestine to stercobilin and stercobilinogen. So it is just a pictorial presentation of what I told about the bilirubin metabolism. There is some difference between the unconjugated and conjugated bilirubin. The conjugated bilirubin is water soluble, normally present in the bile, and unconjugated is insoluble, present in the plasma. Conjugated is loosely bound to albumin. It filtered through renal glomeruli and excreted in bile. It is non-toxic and present in low concentration in the blood. Whereas unconjugated bilirubin is tightly complex to albumin. It is not filtered through the renal glomeruli, and it is not excreted in urine. It is a toxic substance, and the chief form of the bilirubin in the blood is the unconjugated bilirubin. So what is the diagnostic importance of bilirubin? The disruption of the bilirubin metabolism and excretion, it can cause hyperbilirubinemia and jaundice. It may be unconjugated or conjugated. Unconjugated bilirubin is due to overproduction of the bilirubin by reticuloendothelial cells. It can cross the blood-brain barrier, and it can go to the central nervous system, and it can cause kernicterus. Unconjugated bilirubin can occur in the other conditions like physiologic jaundice in the neonates, hemolytic anemia, and toxic hyperbilirubinemia. That is due to toxin-induced liver dysfunction like chloroform carbon tetrachloride or mushroom poisoning. There are some congenital syndromes that is related to uptake and conjugation of bilirubin, that is Crigler-Nazar syndrome due to the decrease in the UDP glucose transferase activity, and another is the Gilbert syndrome. It is due to decreased uptake of the bilirubin by the hepatocytes. Conjugated bilirubin is due to the reflux of the direct or conjugated bilirubin into the blood due to biliary obstruction or cholestasis. Conjugated bilirubin is water soluble, so it is excreted in urine and darken the color. Conjugated hyperbilirubinemia is occur in the following condition. First is the obstructive jaundice or cholestatic jaundice, that is due to the obstruction because of the stones or tumor. A micro-obstruction in the intrahepatic biliary ductus, like in the viral hepatitis or liver cirrhosis. And the last one is the Rotor syndrome or Dubin-Johnson syndrome, that is because of the defective excretion of the bilirubin into the bile canal. Normal range of bilirubin is up to 1.4 milligram per dl, out of which the direct fraction is generally up to 15%, that is up to 0.3 milligram per dl, or indirect should be up to 1.2 milligram per dl. Jaundice becomes clinically evident when the bilirubin level exceeds 2.5, and there are several types of jaundice like hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice. Hemolytic is just because of the increased RBC breakdown. Hepatocellular is because of the inability of hepatocytes to conjugate or excrete bilirubin. And obstructive jaundice is, as I told, that is because of obstruction in the bile duct or there is some problem in the excretion. So these are the types of the prehepatic, hepatic, and posthepatic jaundice with the examples. The another thing is the serum albumin. The normal level is 3.5 to 5 gram per dl, and the synthesis of the albumin depends on the extent of the functioning liver cell mass. It has longer half-life, that is around 18 to 20 days, and its level decreases in almost all chronic liver disease. Serum globulin, the normal level of serum globulin is the 2.5 to 3.5 gram per dl. It constitutes immunoglobulin produced by beta lymphocyte as well as alpha and beta globulin synthesized mainly by the hepatocytes. High level of gamma globulin observed in the chronic hepatitis and cirrhosis. IgG level increase in autoimmune hepatitis and IgA in the alcoholic liver disease. Albumin to globulin ratio should be around 1.2 to 1.5, and the globulin levels increase in hypoalbuminemia as a compensation. Prothrombin time. Actually, prothrombin is synthesized in the liver as a marker of the liver function. Its half-life is 3 hours, and it is prolonged only when the liver loses more than 80% of its reserve. Vitamin K deficiency also prolongs prothrombin time. Next is the aspartate aminotransferase. Its normal range is around 8 to 40. It can vary. It is found in cytosol and mitochondria and widely distributed throughout the body. It is found in the order of decreasing concentration in the liver, cardiac muscle, skeletal muscle, kidney, brain, pancreas, lung, leukocytes, and erythrocytes. So it is not specific for the liver. It is a marker of hepatocellular damage, and its high level are observed in chronic hepatitis, cirrhosis, or liver cancer. Alanine aminotransferase, AST, the normal range is 10 to 30. It is a cytosolic enzyme. It is present in greatest concentration by far in the liver and is therefore more specific indicator of liver injury than AST. So the moderate elevation is seen in alcoholic hepatitis and minor seen in the cirrhosis. A marked elevation of aminotransferase level more than 1,000 is seen in viral hepatitis, toxin-induced liver injury, DILI, ischemic hepatitis, autoimmune, acute Budd-Chiari, Wilson disease, and acute obstruction. Alkaline phosphatase is the marker of, it is the non-specific marker because it is also produced by the bone and placenta. The gamma GT is used for the glutathione synthesis, and it is also elevated in the infective hepatitis, prostate cancers, and it is also seen in elevated in the alcohol abuse. This is the last slide, that is the other test. The other tests are blood ammonia, LDH, alpha-fetoprotein, ceruloplasmin, leucine, alpha-1 AT-procollagen, cholesterol, and glycoprotein. But to explain these things are not scope of this presentation. So I want to conclude here. Thank you. Thanks a lot.
Thank you, Aniket, for your excellent presentation. I want to know what is the importance of R ratio.
So R ratio actually it denotes the hepatocellular injury versus the obstructive things. If the AST ALT is more, we can say it is more likely the hepatocellular injury. If the alkaline phosphatase is more, we can tell that it is the obstructive or cholestatic jaundice.
Good presentation, Dr. Aniket. But I have some questions. During your title of your presentation is the interpretation of liver function test. So I think you may present in this way that if the liver function, for example, if the bilirubin is normal and if it is abnormal, so what fraction of maybe indirect hyperbilirubinemia or direct hyperbilirubinemia, what is the interpretation of indirect hyperbilirubinemia? Suppose if the bilirubin level, indirect bilirubin level is 3, then what's your interpretation? If it is more than 10, then what's your interpretation? You should enumerate the causes of, if the indirect bilirubin is 10, then Gilbert is most likely is not the cause. So you should enumerate the other causes. And how will you proceed?
Yes.
Again, similarly, in presence of cholestatic jaundice, or the ALT-AST, the etiology varies depending upon the level of ALT-AST and whether the ALT is higher than AST or AST is higher than ALT. If the transaminase level is more than 1,000 and ALT is more than AST, then the differentials are different. If the AST is higher than the ALT, then the differentials are different.
Definitely, sir. Yes.
Sir, I have one question.
Yes, Jan.
Sir, I have one question to Dr. Johnson. Sir, like what you have discussed, like indirect hyperbilirubinemia. So in most of the guidelines, like if you take MELD score, we generally take total bilirubin for calculating MELD. But suppose a patient with Crigler-Najjar or Gilbert syndrome has very high level of indirect hyperbilirubinemia, then will you take the indirect fraction for calculating MELD or the total fraction?
No. MELD, and it is important to know that where we can apply the MELD score. The MELD score was originally meant to triage the patient for the liver transplantation in patient with chronic liver disease.
Yes.
It's not meant for the interpretation of all these things.
Yeah. Yes.
Again,
So, will we go for liver transplant or we refer the patient for liver transplant?
No. We should look
Patient
for
for
the causes of indirect hyperbilirubinemia. In patient with typical chronic liver disease, the direct fraction is most commonly raised. But if the indirect fraction is raised, then we should look for the blood disk crisis is present or not, or the presence of any congenital abnormality.
Yes.
Associated congenital, we should look in that way.
Thank you, sir.
You have to take in account other factors. Like if a patient with chronic liver disease presents, he will have ascites, raised prothrombin time, whereas congenital hyperbilirubinemia asymptomatic, only yellow discoloration of sclera and yellow urine. They are totally asymptomatic. So in this case, MELD will not apply. Very rarely, some Dubin-Johnson syndrome may present with chronic alcoholic liver disease, liver failure. So that is a different scenario in here. In that case, you have to take in account of this indirect urine separately, and you have to total combined judgment, looking at the prothrombin time, sodium level. So this is typical different scenario. What Dr. Sanjeev tries to say that the clinical interpretation is case-based clinical interpretation, case to case. Just.
Thank you.
Thank you, Aniket.
Thank you, sir. This was truly an enlightening session. I would request our moderators and chairpersons to kindly remain on the dais, because I would now be inviting our next speaker, Dr. Ravish Ranjan sir, who is a senior gastroenterologist, consultant gastroenterologist at Raj Hospitals. He will be speaking on the topic non-invasive markers of liver fibrosis and their further interpretation. I would request sir to kindly take the stage. I also request our speakers to kindly stick to our time limit. We will have a warning bell at 10 minutes and the final bell at 12 minutes. Thank you.
Good morning, and I thank you organizers for giving me this opportunity. Now, I feel fortunate to give this presentation in presence of two of my teachers, Dr. SK sir and Dr. Ashish sir. Now, to start this presentation, this is a non-invasive assessment of liver fibrosis. As we know, in the natural history of liver disease, fibrosis of liver, the occurrence of fibrosis of liver marks a distinct event in the phases, different phases of compensated versus decompensated liver disease. Now, in my particular topic, I will be more focused on NAFLD, because the fibrosis in NAFLD patients should be ascertained priorly to know the further prognosis of the patients. Now, this is the natural history of NAFLD over 18 to 13 years. Now, there are multiple ways of progression from steatosis to cirrhosis or HCC. Now, a patient may progress linearly from simple steatosis to NAS and fibrosis F1, F2. This is about 12 to 40% patient progress in this manner. Now, the patient from F1, F2 fibrosis to progress linearly to advanced fibrosis, this is in cases of 5 to 10% patients, and from advanced fibrosis to cirrhosis, around 50%, 0 to 50% patients progresses. Now, this is the linear progression. The progression can also be directly from नहीं पहले मेरा वाला होता। Now, sorry for the technical glitch. Now, from advanced fibrosis, from steatosis to cirrhosis or advanced fibrosis, the NFLD can progress directly in about 8% patient to the advanced fibrosis from the steatosis. Not only this, these patients of advanced fibrosis may directly progress to formation of HCC without going to the cirrhosis pathway. So this is a very intricate progression of the natural history of the NFLD patients. Now, initially the liver biopsy was the gold standard for assessing the liver fibrosis in the patient. Now, liver biopsy is essential for diagnosis of fibrosis. Clinical, biochemical or imaging measure cannot distinguish NAS from steatosis. And NFL encompasses steatosis plus one of lobular or portal inflammation or ballooning. Now, NAS requires steatosis and lobular or portal inflammation and ballooning, all three. Now, liver biopsy is an invasive procedure. It may be associated with complications like in 84% patient it can have pain. This is very common. But bleeding, pneumothorax, hemothorax, bile peritonitis, these are rare complications. Now, liver biopsy, there are other limitations. There are intra and inter-observer discrepancies. Measures only one in around 50,000 of the liver tissues, prone to significant sampling error and impractical to perform serial liver biopsy. This is the main limitation, because as we know in the NFLD patient, the progression is sometimes sequential and sometimes it goes directly from steatosis to advanced fibrosis. So each time you go for a fresh liver biopsy is not possible practically. Now, the problem with pathological diagnosis, the pathological features of typical NAS is, in addition to fat deposition in hepatocytes, include inflammatory cells, ballooning, degeneration, Mallory Denk bodies, and pericellular fibrosis. These all, and few NAS patients show all of these typical findings, and there are no integrated criteria to diagnose NAS based on them. So, this is NAS CRN's criteria. We all know that steatosis less than 5%, this is 0. Score, and steatosis more than 66 is 3. Lobular inflammation, none is 0, and more than 4 foci is 3. And hepatocyte ballooning, none is 0, and more than 2 is many balloon cells. And NAS diagnosis requires 4 or more than 4, and at least 1 point from hepatocyte ballooning. The role of non-invasive assessment, non-invasive markers would aim to identify those with worse prognosis, example severe NAS or fibrosis, monitor disease progression, predict response to therapeutic intervention. Early diagnosis is the key to good outcome, as we know. The pivotal issue is there steatohepatitis and fibrosis at an early stage. This would allow the identification of those patients who require strict follow-up, targeted lifestyle intervention for weight reduction, management of components of metabolic syndrome, and evaluate new treatment strategies. Now, non-invasive modalities, there are mainly two approaches. One is biomarker and other is physical method which measures liver stiffness, that is liver stiffness measurement techniques like elastography or ERFI. Now, non-invasive test characteristic, non-invasive test to diagnose steatohepatitis, significant fibrosis. A good diagnostic test should have a high specificity. Other preferable character will be include cost effectiveness and easy reproducibility. Though these are the various biochemical, biomarker and imaging modalities which can be used as non-invasive marker, but in these, USG and CT has no role. Biomarkers like fibro test, FibroC or NFLD fibrosis score, BARD score, fibrometer, FIB4 or BAT score, ELF score, and direct physical measurement like transient elastography, ERFI or magnetic resonance elastography. Now, these are the different studies which produce sensitivity and specificity of different biomarker tests like NFLD fibro scores, fibro test, and these are the various biomarker components that like NFLD measures age, glucose level, BMI, platelet count, albumin, and STL-TSH. Now, FIB4 is a more emphasized biomarker these days, and American Association for Endocrinology in 2024 guideline, it recommends that if a general physician encounters a patient of NFLD or NASH or MAS now it is called, and if it's FIB-4 score is more than 1.6, then he or she should refer that patient to the hepatologist. Now, to calculate FIB-4 these days, we have app-based calculators, and it is easy. In our residencies days, it was a formula which was difficult to calculate, but now app-based calculators are available. These are different, another different, and APRI score is also very widely used. Now, this is NFLD bias, this is a cumbersome scoring system, but now app-based score is present. Now, this is the article which emphasizes natural history of non-alcoholic fatty liver disease and diagnostic accuracy of non-invasive tests for liver disease in severity. Around 3,000 patients were involved, and score less than 1.45 has 90% sensitivity and 60% specificity to exclude advanced fibrosis, whereas a score of 0.676 has 67% sensitivity and 97% specificity to identify the presence of advanced fibrosis. All these tests, biochemical tests, have a high negative predictive value. The FIB-4 test, as I already mentioned, FIB-4 has the ability to identify stage 3 or higher fibrosis. BMI does not affect the score. These are various studies, simple non-invasive scoring system for fibrosis, reliable in patients with NFLD and normal ALT levels. The crux of this study was this. Now, clinical utility, negative predictive value for excluding advanced fibrosis is higher than corresponding positive predictive value. First line risk stratification to exclude severe disease, and predict values depends upon the prevalence rate. Most studies are conducted in this score. Regarding this score, most studies are conducted in tertiary center where pre-test probability of advanced fibrosis is higher than in the community. Now coming to the transient elastography or FibroScan, non-invasive US-based technique in which a low-frequency elastic shear wave is generated by transducer and then propagated through the tissue. Speed of propagation proportional to the stiffness of the cross-sectional area, and the final value is measured on the median of 10 valid measurements. Now, FibroScan is vibration-controlled. It is a patent vibration, mild amplitude and low frequency, 50 Hz. Stiffer the tissue, the faster is the shear wave. This is the principle. 10 measurements are required. FibroScan advantages are it's reproducible, independent of operator bias, and non-invasive, painless, rapid, and patient-friendly. Explore a volume of liver approximately to a cylinder of 1 centimeter in diameter and 4 centimeter in length, 100 times larger than the biopsy specimen. Good prediction of advanced fibrosis and cirrhosis. Now, problems of FibroScan: overestimation of fibrosis in active hepatitis if ALT is more than 5. Unreliable, result in obesity, and failure rates in obese individual. Cannot differentiate intermediate degrees of obesity. Now, this is a particular chart which I want to give you attention. Now, the main application of transient elastography or FibroScan, if it is less than 10 or around 5, it's normal. 10 to 15, it is the liver disease is progressing, and if it is more than 15, then it is compensated advanced chronic liver disease, and if it's more than 25, it can be a case of clinically significant portal hypertension according to the Baveno 6 criteria, and also re-emphasizing Baveno 7 criteria. Now, RFE is another modality. Shear wave elastography is another modality, and MR elastography is expensive, but it's more accurate than FibroScan. Now, these are the various non-invasive assessment of fibrosis. Now, sequential algorithm is most important. Now, another concept is of omics, that is the genomic, epigenomic, metabolomic, and transcriptic proteomics. These identify different markers, genetic markers or metabolic markers to know the stage of fibrosis or whether the patient is at risk of developing decompensation or not. These are various studies, but these are in very early phase of development. Further studies are related. Now, these are the take-home measures. Predict the degree of steatosis and fibrosis important in FLD. Liver biopsy still remain the gold standard, but is wrought with problems. Biomarkers panels to predict fibrosis. Several patented and non-patented panels are available. FIB-4 fibrometer APRI well validated. No single score better than other. NPV high and therefore help in excluding severe disease. And FibroScan and MRE is better, but cost is a problem. Thank you.
Excellent presentation. I have one question. If you have to take the liver biopsy, and what is the criteria?
Yes, sir. Card part. Yes, sir.
If you have to take the liver biopsy, suppose, then how will you know that I have taken the adequate biopsy?
Sir, it's depend upon the number of voter tracts which we biopsed. If it's more than 10, then it's an adequate biopsy specimen. Or if the you want to know the adequacy, sir. So if it's more than
Adequate biopsy, what you have taken, is they sufficient or not?
yeah, if there are more than 10 portal tracts in biopsy specimen, then it is considered as an adequate biopsy.
I think.
Sir, can non-invasive markers predict steatohepatitis?
No, non-specific markers have very low sensitivity for the early phases of fibrosis or steatohepatitis. Only the intermediate and high grade fibrosis are predicted well with this.
And can the marker differentiate fibrosis and cirrhosis?
Dr. Ravi, I have one question. A very nice presentation and
Thank you, boss.
So my question is that in CACLD or in CHPH, generally how frequently fibroscan should be repeated? And second question is, in two fibroscan readings, suppose one saying that it is 14.5 kPa, another is saying 12.5, and again another one is saying 16. So what is the actual difference when you say that there is significant improvement or significant, there is loss of the liver mass? So what is the exact parameter?
Actually, the ideal guideline is to take two fibrosis score at as shortest possible time interval to get the proper picture. Suppose a patient, as you say, boss, one score is 14, one is 12. So this means the patient is in a category of liver disease, but it has not progressed to clinically significant compensated advanced liver disease, CACLD, which is more than 15. So
No, actually my question is that suppose the patient is having 20, suppose. Next time he comes with 18. He is very happy saying, पिछले बार से कम हो गया. But is it कम हो गया or is there any percentage कि इतना से कम होगा, then will you say that it is significant?
So I don't remember any percentage drop in fibroscan score. Perhaps I would like to take.
Is there any cutoffs or like when you say that these two are different or there is significant?
Actually, the idea of improvement in patient's condition or liver condition is extrapolated from the HBPG measurement. In HBPG measurement, when there is a drop in more than 20%, then we can say that liver function has significantly improved. In similar way, the study has been done in taking the fibroscan as a marker of improvement. In fibroscan value, if there is an improvement in more than 20%, then we can say the liver function or status of liver has improved. Or if the improvement is less than 10%, then no significant improvement is there.
Thank you, sir.
Dr. Ravi's nice presentation.
Thank you, boss.
Two queries from my side. Number one, fibroscan in morbidly obese. How to select patient and how to select the probes. Number one. Number two, as Dr. Sanjeev alluded to, regression of fibrosis has to be documented anyhow. Do we have any protocol? How frequently we do that, and what's their validation? Are they really helpful in documenting the regression?
Sir,
Thank you.
Thank you, boss. As far as the protocol for repeating test for fibroscan test in a patient, it has been said by that you should repeat the test after 1 year of the therapy. And regarding your first question,
Morbid obese, how to select patient and
actually
how to select probes?
in morbid obese patients, we usually use Excel probe for the patient. And for the selection criteria, I don't remember exactly what was the selection criteria upon what BMI, the exact value of BMI upon which we use Excel probe.
Okay, thank you.
Actually, most of us fibroscan setting we don't have Excel Pro because it's costly.
That is the issue. That is.
So that's a limitation. Those who are having Excel Pro, it's good, but the majority of us don't have Excel Pro, even in big hospitals maybe.
What I have seen nowadays very popular FibroTouch. So what we are doing in clinical practice, but this test has many fallacies. I have seen in even 7 to 10 patients of cirrhotics, FibroTouch is normal, but when go for the RF-based elastography, that sees ultrasound, that is a real-time image, as well as portal vein diameter, as well as fibrosis in different quarter. So I think in obese patient and in cirrhotic patient, in the fibroscan is coming normal score, RP-based elastography is the best tool to do. RP-based elastography.
Is it in those selected patients or?
In obese patient it's helpful, obese patient.
But again, the limitation will be same because ultrasound probe is there for obese patients. So same limitation in all ultrasound probe because obesity.
What is really helpful in RP-based elastography? The literature supporting. But I have done 2000 in Apollo clinicals and it's very, I paired 50 to 70 patients biopsied. And it's really better. It's published in abstract form and it's supported.
So you said that no single test is better than the other test. Then what's the utility of combination of this test? Like the many scoring system has recently been introduced. The FAST test, the FibroScan plus AST, MEFIS, the MRE plus FIB4.
Yes.
So is there any study?
Sir, I don't know the studies.
Thank you.
I'm frequently using this FIB4 score. It's a very easy. If in clinic, it's a very useful. It's just you can Google it, and hardly 15 seconds it's actually required for a FIB4 score, and it has more than 80% success.
Yes.
Regarding FIB4 score, do you think, sir, the labs give the platelet count reliably enough to use it clinically? What we find in our clinical practice is
what we find in our clinical practice is the platelet count is something which is not reliable most of the time. We come across patients with frank cirrhosis with portal hypertension and the platelet count is reportedly normal. So in my experience, I think the FIB4 is challenging there because we do not get a reliable platelet count, and platelet count is an important parameter here.
So if we see the negative predictive value of all these FibroScan, FIB4, API, so that's why it's not 100% effective, 86, 88%. So that actually because of that only, because of platelet counts or because of sometimes patient is not adequate fasting and then AST, ALT value is different with fasting, and so we have to inquire about that. Is it reliable report and patient was in fasting because AST, ALT value vary after.
And regarding the monitoring of patients of NFLD with FibroScan, I think it is still to be validated regarding monitoring of the patient on follow-up. It is validated for initial diagnosis, but for the subsequent like 3 months or 6 months, there is still lack of studies which we can reliably say that. So it is still not validated for monitoring per se.
Yes, exactly. I agree. It's not recommendation for monitoring FibroScan for monitoring of these patients.
Thank you, sir.
I request our chairperson to kindly felicitate our speakers. I request our chairperson, sir, Dr. M.L. Prasad, sir, to kindly come to stage and felicitate our speakers. I request Dr. Chandan Kumar, sir. I request our speakers, Dr. Aniket, sir, Dr. Ravish Ranjan, sir, to kindly come to the stage.
Wonder sir, Ashish sir and Sanjeev sir, please be on the desk to felicitate our speakers.
I request Dr. M.L. Prasad, sir, to felicitate our moderators for the session. Moving on to the next session, I request our chairpersons, Dr. Shri Hari Anikandi sir, Dr. Vijay Shankar sir, and Dr. Jayant Ghosh sir to kindly take the stage. I request our moderators, Dr. R.S. Sahu sir and Dr. Sangeet Saurav sir and Dr. Ajay Chabra sir to take the stage. Our next speaker, Dr. V.K. Dhandania sir, is a senior diabetologist at NMSS Hospital and Santa Vita Hospital, Ranchi, an alumni of ISB Hyderabad and IIM Ahmedabad. Sir has around 20 international and national journals to his name and is very actively involved in educating and spreading awareness regarding diabetes. He will be speaking on the topic metabolic dysfunction associated steatotic liver disease, a contributor or association to type 2 diabetes.
Good morning. Respected seniors, dear friends. Hello. Yeah. Good morning, respected seniors, dear friends. Thank you for that very kind introduction. At the onset, I would like to thank the organizers, especially Dr. Jayant Ghosh and his team, for giving me this opportunity. I acknowledge each and every one of you for being here this early morning. My topic is, I've kept it NFLD because MASLD is a newer terminology which has recently been updated, but we don't have much data in association with MASLD today. And I will talk how NAFLD and MASLD are differentiated. I don't have any disclosure for this presentation. So NAFLD is one of the most common and important cause of liver disease, and you will be hearing more and more in this particular conference. and will probably emerge as the leading cause of end-stage liver disease. Earlier, we used to learn chronic alcoholic liver disease, ALD, and all the complications of alcohol in liver disease. But now it's the other way around, non-alcoholic liver disease. Now, how NAFLD differentiates from MAFLD? NAFLD is steatosis, liver fat, plus absence of secondary causes of steatosis like alcohol, drugs, something like less than 30 grams in males and less than 20 grams in females. That is how you actually draw a line for alcoholic liver disease. And you also rule out other causes like hypothyroidism, you can rule out Wilson's disease. There's a list of other diseases, viral markers, autoimmune markers. And MAFLD is a metabolic dysfunction associated fatty liver disease, steatosis plus, overweight, type 2 diabetes on medicines, and metabolic dysfunction, at least 2 of them, waist circumference more than 40 in men, more than 35 in women, very, very prevalent in Indians, blood pressure more than 130/85 or on medications, elevated triglycerides more than 150, low HDL cholesterol less than 40 in men and less than 50 in women, pre-diabetes, HOMA-IR, that is insulin resistance more than 2.5, and CRP more than 2. So these are very, very similar markers for even metabolic syndrome, and it does not exclude alcohol use. So this is how you differentiate between the two. And NAFLD without MAFLD may be a lower risk, but MAFLD may identify a higher risk. That is a real big difference in both of them. This was one of the publications recently I got in a newspaper. बिना शराब पिए भी खराब हो रहा है बिहारियों का liver. This was a meeting in Darbhanga. This was RSSDI Darbhanga meeting, where it was presented that in spite of restriction of alcohol, there is more and more of non-alcoholic liver disease in people from Bihar. So definition of NAFLD, NAFL and NASH, we all have listened. NAFLD has excessive hepatic fat, steatosis in 5%, more than 5% of hepatocytes, exclusion of secondary causes. It could be 2 types, NAFL, that is non-alcoholic fatty liver, pure steatosis and mild lobular inflammation, and NASH, which can be again 3, early, fibrotic and cirrhotic, and cirrhotic can finally progress to, in some patients, to hepatocellular carcinoma. This is the definitive diagnosis of NASH, requires a liver biopsy. We heard in the previous lecture. Clinical presentation, it could be asymptomatic in most of the patients. Sometimes patients do complain of post-meal pain in the right hypochondrium. Typical presentation includes increased ALT and AST raised factors associated with insulin resistance like obesity, high TG value, high glucose values, low HDL, hypertension. These are the testings we should do to rule out other causes, viral markers, autoimmune panel, iron and ferritin, serum ceruloplasmin, alpha-1 antitrypsin, TSH, and even LFT. We all heard about in the previous lecture. I'm going to actually go faster. This is the spectrum of NAFLD, which again we learned in the couple of lectures earlier. Healthy liver, fatty liver, NASH, cirrhosis. And this is one important association with genes. Several genetic modifiers of NAFLD have been identified, but a minority have been robustly validated. And one of them that is validated is PNPLA3 I148M and the TM6SF2 E167K variant have a higher liver fat content and increased risk of NASH. This is one very interesting slide, and I heard a few discussion been made in the previous lecture. This is a very, very interesting slide which can be followed in clinical practice, and this is for all of us sitting here. Patients, how you need to risk stratify our patients is on the basis of high risk group for NAFLD is a pre-diabetes or type 2 diabetes, obesity, and more than 2 cardiometabolic risk factors with steatosis on imaging with raised AST or ALT. And patients need to have a fibrosis risk stratification. Low risk if the FIB score is less than 1, FIB4 score is less than 1.3. And I was happy to hear that people are very comfortable with FIB4 score, and we too are actually using in clinical practice. I, being a diabetologist, I do it in my clinical practice very easily. And I'm happy to say here that people are concerned about the platelet values, and it's really big challenge, especially if you are getting a report from outside the city, patients blood sample is been collected and sent to Bombay or sent to Delhi for getting a report, those platelets values are definitely absurd. But if you get a platelet value done in your city, in your lab, that will give you a more authentic values. And then the indeterminate risk, you can order a second test, liver stiffness measurement by elastography, or ELF is another test which can be done, but it's not easily available in our country. ELF is enhanced liver fibrosis blood test, where they do 3 tests at one time: hyaluronic acid, they do a collagen 3, and they also do metalloproteins which are being done, and all 3 put together in an app will give you a score, a low risk score, an indeterminate risk, and a high risk. This is supposed to be having a very high sensitivity and specificity, but at the moment this is not available easily in our country. Very few labs are doing it with, it's very expensive also as well. It's managed by primary care team, so you can imagine all of us can do it. All the primary care physicians can do it. Endocrinologists, others can also do it. Focus care on obesity management and CVD prevention. This is also very important because NAFLD patients die more of CAD than actually because of the liver complications. Referral to liver specialists for additional proprietary biomarkers or imaging like MRE, CTI, others, and multidisciplinary team to prevent cirrhosis and CVD. So this is one slide which gives a lot of inputs to how do we do in clinical practice. Now, regarding association of NAFLD and diabetes, now childhood obesity has become a real big problem. We see a lot of children with obesity today, and even PCOS in young ladies is very, very common, which comes with obesity. And right, if you see the two of here, SIRD and MOD. SIRD is severe insulin resistance diabetes, and MOD is mild obesity related diabetes. These two are very, very prevalent today. Unlike the type 1 diabetics in children, now we see even type 2 diabetics and obesity induced diabetes are very common in children today. The data is very interesting here. The Masala study, where they actually measure the visceral versus hepatic fat, and here 892 children with NAFLD were evaluated. Mean age was 12.8 years, BMI 31.8 kg per meter square, 16.8% developed type 2 diabetes. So can you imagine the percentage of conversion to diabetes from NAFLD is very, very high. 1 in every 6 obese children coming to your clinic are going to be future diabetic. And the important thing is, if you intervene very, very intensively at this age, you can prevent these numbers. And risk for development of type 2 diabetes in females. So conclusion is, incidence of type 2 diabetes in children is 30% greater than previously reported pediatric population. This is a very recent publication 2 years back. So again, we have a lot of data from different world over, Japan, Korea, Australia, France, Japan. So there are a lot of multiple studies which we have, and which clearly suggest that NAFLD is first to come, and then it's a very high risk for future conversion to diabetes. And if you see any overweight or obese individual, evaluate them for LFTs and do an ultrasound or do a palpation to see whether the liver is palpable clinically. Look for fatty liver and put them on prevention of diabetes as well. Another study which was published 2 years back was incidence of type 2 diabetes in children with NAFLD, and this is again a very interesting study which was published in June 2022, which clearly shows that type 2 diabetes is a growing problem in children. Children with NAFLD are at a potentially high risk of developing type 2 diabetes. And however, the incidence of type 2 diabetes in this population is unknown. These studies aim to determine the incidence. And if you see the conclusion, it was found it was very, very high risk, and the targeted strategies to prevent type 2 diabetes in children with NAFLD are needed. So this is again one area which is very, very important. Sex hormone binding globulin is another area which is very important. We all know that in obese individuals, in males, testosterone is less because of SHBG, because intrahepatic lipids accumulation is raised, and the risk of type 2 diabetes is high. So if you reduce the IHL values, you increase the SHBG, you increase the testosterone, and you reduce diabetes here. So this is the pathophysiology of NASH, which you've been listening. The newer things in the pathophysiology are BMP4 and ghrelin-1, which regulate hepatic cell senescence during clinical progression of NAFLD and NASH. These are the important markers of future intervention. Transcriptomics, which I heard in one of the slides in the first lecture, identified thrombosporin 2 as a biomarker for NASH and advanced liver failure. And liver fibrosis activated transcriptional networks govern hepatocyte programming and intrahepatic communications. Why these markers are important? Because if you intervene this, you are even going to prevent diabetes in future. The common link, NAFLD, metabolic syndrome, diabetes, insulin resistance, and abdominal obesity. This was the first study to get published from Korea in 2021, where they found that NAFLD and the risk of type 2 diabetes. If you see non-fatty liver, diabetes conversion was 17%, but fatty liver conversion was 47% to diabetics. So again, fatty liver has a higher conversion to diabetes than non-diabetics. Fatty liver predicts future development of type 2 diabetes independent of insulin resistance and baseline plasma glucose. And sustained NAFLD is associated with a lot of complications, early complications in diabetes, especially macrovascular complications, CAD, CVA, or even peripheral vascular disease. So NAFLD severity risk and type 2 diabetes is very common. One very interesting study which came from Tübingen family from Germany was a novel concept of pancreas fat insulin signaling, a crosstalk between fatty liver, pancreatic fat cells, and inflammation in IGT. This is a very interesting study, and which actually addressed why what pushes people from insulin sensitive status to insulin resistance with fatty liver, what underlies the pathophysiology. And you will see that a lot of obese individuals, they can be metabolically healthy obese or they can be metabolically unhealthy obese. And the reason being, they have a subphenotype of benign fatty liver, or they can be having a malignant fatty liver. The reason could be there's an entity called as fetoin A, which is a hepatokine released from the liver, this fetoin A. This actually acts on the TL4 receptors in the immune cells and causes micro-inflammation, localized insulin resistance, peripheral insulin resistance. So this is one very interesting crosstalk which was been published, and it's a very interesting to see that how if you measure this fetoin A, if the patient has got a higher levels of fetoin A, is likely to progress to NASH and fibrosis and cirrhosis of liver faster than patients who don't have fetoin A. So fetoin A is an endogenous agonist to toll-like receptor 4 and regulates insulin resistance and inflammation. It acts as an endogenous ligand to TL4 to promote lipid-induced insulin resistance, and fetoin A is a major carrier protein of free fatty acids in the circulation. So this is another important area of research and treatment in the near future, which is going to be important for all of us. Perivascular adipose tissue is again very important, is an important target of hepatokines, specific fat depots with impact on organ functions. The adipose tissue surrounding arteries seems to have an influence on whole body insulin sensitivity and independent of other fat compartments like hepatic fat and visceral fat. So fetoin A correlates with insulin resistance, fat acid signaling is impaired, so the macrophages are increased, the clusters of fat cells in the pancreas found in close vicinity to islets and sometimes even within the islets. So you can imagine that even the beta cell dysfunction which has been seen in obesity and with metabolic syndrome is because of macrophage infiltration at the level of beta cells. So this is a very interesting crosstalk from adipocytes to liver to pancreas, and that is one of the reasons why this we see that NAFLD is associated with higher prevalence of type 2 diabetes in individuals with obesity and overweight and metabolic syndrome. So we need to address these few hepatokine biomarkers in near future when they are going to be available, and these are the areas of intervention which can be there. There is even impaired insulin action in the brain as well. So at the level of hippocampus, memory formation, prefrontal area, hypothalamus, and fusiform gyrus. So again, fat cells respond with an inflammatory response activating macrophages, leading to all these possible complications of fatty pancreas, fatty liver, obesity, unfavorable fat distribution like visceral adiposity, then subcutaneous adiposities. So if you see again, the AAC guidelines very categorically says that for the treatment and diagnosis and management of NAFLD, it's very important that we follow certain guidelines, and they are really very, very helpful, which can be easily followed in our clinical practice. So consequence for prevention of type 2 diabetes is very important here. That was the basic reason of keeping this topic, that NFLD, when you see, put everything intensively for prevention of diabetes. This is one area where we can actually stop the epidemic of diabetes which is going on from childhood to adulthood, because we are seeing a lot of diabetics at the age of 25 and 35, and which is very, very common today. And you can imagine getting a diabetes at 25 will be a dialysis at the age of 45 and 50. So that is where we need to intervene so intensively. So to summarize, abdominal obesity, insulin resistance link NFLD with metabolic syndrome and type 2 diabetes. NFLD plays a key role in genesis of hepatic insulin resistance, and it's a precursor of metabolic syndrome rather than its hepatic manifestation. NAFLD increases the risk of incident type 2 diabetes by amplifying its physiological determinants, and intervention in reversing NAFLD may be a rational approach in prevention and treatment of metabolic syndrome and type 2 diabetes. And it very well correlates with the previous lecture, where you can actually evaluate a patient very, very intensively at all the different stages of NAFLD and intervene, so that we can prevent not only progression of NAFLD but also prevent the new onset of type 2 diabetes. So I thank you all for your patient listening, and I thank the organizers once again for this opportunity. Thank you.
Thank you, Dr. Navina. That was a very elaborative and a very insightful presentation. I invite questions from the members of the audience, if any, please. Any questions from the audience, please?
So that was a very interesting point that you raised, that NFLD is a precursor, we should consider it as a precursor to diabetes rather than it being a part of the spectrum of NFLD. But so like in our routine practice, we hardly see any ultrasound which is not reporting any fatty liver. Everybody comes with an ultrasound report which says it is grade 1 fatty liver. Does that mean that all these patients, eventually all patients, are at a risk of developing diabetes in the future, or do we need to identify a specific subset among these people who will be at a higher risk?
10 days back, my ultrasound has been done, no fatty liver.
Lucky for you, but I think, 95% of the ultrasounds I see are grade 1 fatty liver.
See, this is what I am saying. See, the fatty liver reporting is subjective also. You need to compare with the contrast of the kidneys when you see a fatty liver. So, clinically, you have to correlate your report. This is what is very, very important. The patient is obese, patient is having metabolic syndrome, patient is having impaired glucose tolerance, hypertension. You can definitely well correlate. You need not do even an ultrasound for these patients. And you can assume these people may be having some pathology in the liver. But someone having a normal BMI, little bit of waist circumference which is abnormal, and not having any component of metabolic syndrome, you have to put brackets with a fatty liver grade 1. And it's always good to put each and every individual for prevention of diabetes. Because each and every one of us are at a very, very high risk of diabetes in this epidemic which is ongoing. And the way diabetes is increasing is phenomenal and very, very surprising as well. We don't know what is actually triggering. There are a lot of things people say, post-COVID vaccination, there is an increase in insulin resistance, there is an increase in, people had asymptomatic COVID, herd immunity, which has caused antibodies that is causing increase, hypercoagulability, all the features of metabolic syndromes are raised. So you never know what is ongoing, but we are seeing a phenomenal increase in new onset of type 2 diabetes.
Sir, one question.
Yes, sir.
How do you choose?
Sir.
Sir, how do you choose OHA in the patient with a fatty liver who is progressively having?
Please switch on the mic. Switch on the mic, please.
So this was the slide for your question, sir. The OHAs which we are actually using for patients who have proven fatty liver and NASH is metformin, pioglitazone, and SGLT2 inhibitors plus minus GLP-1 receptor agonist. These are the 4 drugs which have been approved in treating hyperglycemia in patients with NAFLD or NASH with fibrosis or without fibrosis. All 4 of them are known to decrease the fibrosis and the ongoing inflammatory process in fatty liver patients. So these are the only 4 drugs approved, sir. Metformin, pioglitazone, then GLP-1 receptor agonist and SGLT2 inhibitors. We have data to support all of them, but I was just given 10 minutes time. I spoke to Dr. Jayant Ghosh. He says, sir, 10 minutes khali bolna hai. So I have removed most of the slides as far as treatment is concerned. I kept only a synopsis of that particular slide. We have data with empagliflozin, we have data with semaglutide, and the newer drug which is coming is tirzepatide, and another one, retatrutide, which is coming is a triple agonist, which is going to be a real blockbuster for treating NAFLD in future.
Thank you, sir. That was an excellent presentation. Thanks a lot.
Thank you.
We move on to the next session, please.
Thank you, sir. For the next session, I would request Dr. Pandit, sir, to join us as the chairperson on the dais. I would also request Dr. Sanjeev Kumar Sinha, sir, to join us as the moderator for this session. I would now invite our next speaker, Dr. Chandan Kumar, sir, consultant gastroenterologist at Curesta Hospital, Ranchi. He will be speaking on one of the major complications of liver cirrhosis, that is acute kidney injury.
A very warm good morning. The topic is very large. I'll try to brief up in very few slides. So the content will be the definition, types, pathophysiology, diagnosis and treatment in brief. So AKI defined as increase in serum creatinine greater than 0.3 mg per dl in last 48 hours, or 50% increase in serum creatinine last 7 days if baseline creatinine is available, and decrease in urine output less than 0.5 ml per kg per hour, persistent for more than 6 hours. And HRS criteria from International Community of Ascites in 2007, cirrhotic with ascites with a creat of greater than 1.5 and insufficient improvement after 48 hours of diuretic withdrawal and albumin infusion, absence of shock and intrinsic renal disease without any concomitant use of recent nephrotoxic drugs. As far as acute kidney injury in cirrhotic is concerned, we divide them as pre-renal, intrinsic, post-renal and HRS. So this is the spectrum. Pre-renal falls in of all the patients having renal injury in cirrhotic patients, pre-renal approx covers 70%, then intrarenal like glomerulonephritis or ATN, bilirubin nephropathy is described for 29%, and post-renal obstructive pathology in 1%. And out of all these pre-renal AKI, 60% responds with volume expansion, and the rest of the 34% non-responding to volume 3 falls in HRS type 1 and type 2 as our classical teaching concerned, with 25% falls in type 1 and 9% in type 2. And the common causes of volume responder AKI being sepsis, GI hemorrhage, diarrhea, over-aggressive use of diuretics, NSAID, CCT when done for a screening of SSC sometimes. So AKI approx is prevalent in 15 to 25% of the hospitalized cirrhotic patients. And in SBP we have 30%, alcoholic hepatitis in 25%, and LBP, a serial LBP can account for 10% of the total cases. So this is a pathophysiology in brief. We have portal hypertension, liver failure, leading to increased gut permeability, bacterial translocation, then PAMP release causing activation of innate immunity, which leads to release of reactivation of reactive oxygen injuries and pro-inflammatory cytokine, leading to arterial vasodilation because of increase in nitrates and other neurotransmitter causing adrenal dysfunction, HE, HRS and renal dysfunction. So these are the certain mediators, not going in detail. So coming in brief about the diagnosis, so HRS type 1 is rapid progressive renal failure with doubling of creatinine more than 2.5 in less than 2 weeks and 50% reduction of initial 24-hour creatinine clearance less than 20 ml per minute in less than 2 weeks, and usually develops after a precipitating event with a median survival of 1 to 2 weeks. Type 2 is a moderate severe impairment which is having a steady progressive course that evolves over weeks to months, with a serum creat of 1.5 to 2.5 mg per dl, and develop de novo in patient with a refractory ascites with a median survival of 6 months. And this is ICA criteria. This is a We'll talk the newer one. In brief, the definition of AKI in cirrhosis: increase in creatinine more than 0.5 mg per dl within 48 hours, or 50% increase from the baseline in prior 7 days. So this is the new added diagnostic criteria. We have an added component of urine output of less than 0.5 ml for more than 6 hours, and pictures, biochemical pictures suggestive of renal vasoconstriction in form of fractional excretion of sodium of less than 0.2%, with less than 0.1% is a highly predictive of HRS AKI. And this is the new classification for HRS subtype. We have HRS1 now being new classified as HRS AKI. However, our all data are studied in context with type 1 and type 2 only. HRS AKI have been defined as absolute increase in creatinine of more than 0.3 mg per dl within 48 hours with decreased output of less than 0.5 ml, or percentage increase of 50% from the last available creatinine within the 3 months. So time period is 3 months. And in HRS2 have been subclassified as HRS non-AKI in NAKI with AKD, acute kidney disease, and CKD. The difference is about the duration. When GFR is less than 60 ml for more than 6 months, we call it HRS CKD, where a patient being considered as a simultaneous hepatorenal liver and kidney transplantation. And then HRS AKD, where the same persists for less than 3 months in absence of structural causes. So this is a brief about the treatment. Initial once AKI has been diagnosed out, we remove the risk factor in form of withdrawal of the nephrotoxic agents like diuretics, vasodilators, NSAIDs, and beta blocker 2. We go for expansion of plasma volume with albumin and treat the infection wherever found, including SVP and UTI. And look, after the withdrawal of diuretics and volume expansion of 1 gram per kg, though our patient doesn't tolerate it out, we look for a response, whether there is a response. If patient responded, we go ahead with the volume expansion only in the withdrawal of precipitating agent. And if patient meets the criteria of HRS, then we go ahead with the vasoconstrictor and albumin therapy. Then we go for a nephrology consultation for the further management of AKI, where the patient requires future intervention from nephrology side. So these are the 3 important differentials. We have HRS, ATN, and glomerulonephritis. So it is urine FNA with less than 20 ml equivalent. We differentiate HRS from ATN. And fractional excretion of sodium less than 1. Less than 0.1 is very predictive. And in ATN we have more than 2. And urine osmolarity greater than 500 in HRS, and ATN we have osmolarity of less than 350 with bland urine segment. They support the diagnosis of HRS rather than having any intrinsic renal pathology as a cause of renal dysfunction in cirrhosis. So these are some of the newer urinary marker in AKI which helps in differentiating other causes. So we have Angel and interleukin 18, outscore, scheme, and fatty acid binding protein. We have a significant data in differentiating this HRS from ATN. So Angel and interleukin 18 is the preferred newer research molecule that helps in differentiation. So as far as treatment is concerned, we have 4 modalities. Vasoconstrictor therapy, the traditional one, TIPS being experimental, extracorporeal support system MARS is an experimental, and liver transplant with or without kidney transplant is the answer of choice. Terlipressin in HRS, this is a study from Dr. Sanyal sir, SGPJ Lucknow. This is a classical study where they have taken the dose of terlipressin 1 mg every 6 hours with albumin dose of 25 gram per day. And they divided the patients as a partial responder and non-responder. In partial responder, there was a decrease in serum creatinine of more than 0.5 mg per dl. So they continued the treatment till 14 days. Or till the treatment failure occurs. And they study this 90-day survival need of renal transplant therapy and predictors of HRS. However, there was a significant difference in reversal of HRS, but there was no any significant difference in 90-day survival in this study. The same with other groups too. The predictor of survival in terlipressin HRS is lower MELD score, lower serum creatinine, lower serum bilirubin, and absence of alcoholic hepatitis. This is one of a very important factor that predicts the poor response of terlipressin in HRS subgroup. And this terlipressin versus NORAD, in a simple statement, we can say NORAD is a poor man's choice for the management of HRS and cirrhosis with equal efficacy without any survival benefit. So this was the study between showing difference between terlipressin and NORAD, and we have equal reversal rate as in both the group of terlipressin and NORAD without any significant survival difference. So this is a meta-analysis also that support NORAD is as effective as terlipressin without any survival benefit, and it's a cost-effective one. As far as midodrine is concerned, it's an alpha agonist. We start at a dose of 7.5 mg TDS and we increase gradually up to 12.5, and we titrate with a MAP to increase from the baseline up to 15 mm of Hg. And midodrine has been used in association with octreotide at a dose of 100 microgram subcut TDS that has been increased up to 200 microgram. And this combination therapy has been compared with terlipressin and albumin, and terlipressin outscores. So terlipressin with albumin remains the first line of choice in the management of HRS. Then midodrine plus octreotide can be used as an alternative in cases where terlipressin which is not feasible practically. We have accessibility of both the medications. Found to have lower efficacies with lower survival, and head-to-head trial need to be done with a large sample size to comment further on the same. And tips: being an experimental therapy in the patients who haven't responded with terlipressin and IV albumin infusion. So in this study, they have done in 14% of 40 patients of HRS type 1 who underwent TIPS, and 17% of type 2 HRS underwent TIPS. And median interval in type 1 was 2.2 weeks, means failure of therapy with terlipressin and albumin, and type 2 it was 4 weeks. Type 1 HRS had a more advanced degree of liver dysfunction. So the outcome was renal function was worsened in a patient who didn't went TIPS, who have failed with vasoconstrictor therapy, and 23% of the non-responder died. However, the reversal rate was significant as so in the data table 2. And TIPS in the refractory ascites and type 2 HRS, we have no survival defect, but however, it does decrease the risk of ascites recurrence and HRS progression. This is an experimental therapy where we go for a MARS that have shown significant decrease in the creatinine and bilirubin level with simultaneous improvement in HE. A brief talk on the indication of some of the studies on LT in HRS AKI. So 71% who have fulfilled the ICA criteria, they underwent the transplant, and none of the patients who have been transplanted required any long-term renal transplant therapy, with a significant decrease in the mortality. And one thing is that this presence of HRS in liver transplant is a poor predictor, and the mortality rate is 18.3 in a patients of cirrhotic who underwent transplant with HRS and without HRS. And some of an condition where we can consider for combined liver and kidney transplant. So chronic kidney disease requiring dialysis, mostly in the diabetic NASH-induced cirrhotic patients, we have CLD and CKD both. CKD not requiring dialysis, but GFR of less than 30 ml per minute with a proteinuria of more than 3 gram within 24 hours. And the patients who have sustained AKI which require dialysis at least for 4 weeks or 6 sessions of for a 6 consecutive week. Sustained AKI not requiring dialysis with GFR of less than 25 ml for 6 weeks or more by MDRT6 definition. And sustained AKI patient may also qualify for chronic liver kidney transplant, combined liver kidney transplant listing, if they fulfill the criteria C and D for total of 6 weeks and presence of metabolic disease. So this is an LT. Duration and the degree of HRS or renal dysfunction preoperative have a greater impact, and it's an independent predictor of survival in transplant setting. So the summary being, Tips remain an experimental therapy, and liver transplant is the only effective treatment if patient is not responding with vasoconstrictor and IV albumin expansion. Thank you.
Thank you so much, Dr. Chandan. That was another wonderful presentation. We welcome any questions or comments from the audience, please.
So I think I have one comment and one question, sir. So excellent talk. So one of the criteria that has been given for type 1 is a creatinine rise of 0.3 milligram percent, which is a very small absolute value. But I think most of us neglect that even small rises in creatinine do really indicate that there is kidney injury going on. That also comes with a caveat that you're doing this sample from the same lab again and again, because if you do it from 2 different labs, the values turn out to be different. I have faced this lack of attention to detail, that smaller rises of creatinine you're not worried, you only look at the absolute creatinine values, which I think is a wrong mistake that we do. My question is, you told us about the dual liver kidney transplant, but often we face the situation that this is a patient of CKD and there is a doubt that patient also has some underlying chronic liver disease. You do a fibroscan and it comes to around 12, 13 borderline values, maybe higher fibrosis, early cirrhosis. So in such cases, and the patient is due for a kidney transplant. So should you recommend that this patient should undergo a dual transplant, or only if the patient has a decompensated liver disease, only then he should undergo a liver and a kidney transplant, and now we can go ahead only with a kidney transplant and be under follow-up? Is there any guidelines for that?
Unlikely, sir. I haven't encountered such guidelines, but under such scenarios, 2 or 3 patients have been referred from us, and they had an advanced fibro scan score of approx 36 with advanced fibrosis on liver biopsy. Patient went into, I think, ILPS. And they do have a point to go ahead with plain renal transplant only, because unless and until symptom of decompensation occurs, it's too early to embark on the same for simultaneous, because the availability of the organ is also an issue. For a family to donate both kidney and liver.
Yeah, but that also comes with a caveat that he's undergoing one major organ transplant, and you have not told him about the probability of undergoing another organ transplant, which is a huge ask for the family.
So possibility patient may land up in ACLF, as which we encountered during bariatric surgeries. Patient is undergoing for a bariatric surgery, and because of underlying advanced fibrosis, patient is going to land up in ACLF. So the status of liver transplant in this advanced fibrosis is still unclear without any common consensus.
So in such cases, what we usually do, I don't know if it is right or wrong, I've not seen any clear guidelines on that. We do HVPG in these patients and see if there is any clinically significant portal hypertension. So if HVPG is more than 10 or 12, probably these are the candidates who will very soon white lined up with a advanced liver disease, and we offer a dual transplant to such patients. I am not sure if there are any guidelines. I could not come across. I don't.
So the answer lies in whether the patient fulfill the criteria of liver transplantation at the time of kidney transplantation or not. Again, even if the disease is patient has compensated advanced chronic liver disease, but it does not fulfill the criteria of liver transplantation. So in that case, the simultaneous transplantation is not needed. We may tell the patient that the liver transplantation may be possible in future. So the sequential transplantation may be a possibility in those group of patients, but the simultaneous transplantation is not the answer. One of my question is, or comment is, while starting, before starting the terlipressin therapy, we should ensure about the status of kidney disease, whether the patient is suffering from actual HRS or has developed ATN, because terlipressin has beneficial effect on HRS but has deleterious effect on ATN. So it is very important to differentiate the HRS from ATN before starting terlipressin. My question is how to monitor the terlipressin therapy.
Sir, in terlipressin therapy, we have two terminal points. One is three non-responder, partial responder, and the full responder. So in full responder, we have a 50% decrease in the serum creatinine from the baseline availability. In that situation, we continue the therapy till 14 days or 2 weeks of the recommended therapy. In partial responders, we have a less than 50% decrease by 7 days. And non-responder, there is no response. Non-responder is an absolute criteria for transplantation. And in partial responder, we can continue the therapy till 14 days, and then we can look up to whether the patient has responded. If patient has lined up or patient is having type 2 HRS, the possibility of reversibility will be less, or HRS Naki.
Would you like to increase the dose of terlipressin?
Sir, from what, sir. Initial dose is 1 mg IV every 6 hourly. That can be increased up to 2 gram IV 6 hourly. And in some of the studies, they have increased the albumin dose by the day 5 to the double dose of the initial dose to look upon the response of the therapy.
Day 5 or day 3?
Day 5 in partial responder, sir. In non-responder, no idea, sir.
Thank you so much, sir.
We usually proceed with, I think, injectable in every 6 hours rather than infusion, I think.
So there are a study by P&J, I think 4 or 5 years before, that showed the continuous infusion of terlipressin is more safer, though equally effective than the interval bolus terlipressin.
Okay. Thank you so much, sir. We wrap up the session. We hand over the session to the organizers, please. Thank you.
Thank you so much, sir. We will now request our chairpersons to please felicitate our moderators.
টিভিতে কি আছে 11:30 বাজে দেখে চাই চাই না হলে ভিন্ন হয়ে যায় বাহারে আছে
I would now request the moderators to please felicitate our chairperson. I would request Dr. Jayan Ghosh sir to please felicitate our speakers, Dr. V.K. Dananya sir and Dr. Chandan Kumar sir. So we start off with the next session. And the speaker for the next session is Dr. Amya Ranjan sir. He'll be giving light on the topic of hyponatremia and cirrhosis. He's a senior gastroenterologist at the Tata Main Hospital in the Jamshedpur. The moderators for this session will be Dr. Sangeet Saurav sir, Dr. Sandeep Agarwal sir, and Dr. Neha ma'am. The chairperson for this session will be Dr. Ravish sir, Dr. Aniket sir, and Dr. Shalini ma'am.
Good morning. So, the topic for my presentation is hyponatremia and cirrhosis. It's a complex topic. I'll try to simplify it as much as possible. We'll first discuss the few definitions. The classical definition is a serum sodium less than 135. Although in cirrhosis, there are many consensus where the sodium less than 130 is considered is considered hyponatremia. Severe is less than 125. The clinical implications are broad. Patients with serum sodium less than 135 have a higher risk of ascites, encephalopathy, renal failure, sepsis, and high in-hospital mortality. Also, they have increased likelihood of developing SBP and hepatorenal syndrome. Severe ascites, often associated with refractory ascites, is common in patients with serum sodium less than 135. So we'll start this and hope we're not stuck with the image below. The classification, hyponatremia, serum sodium less than 130, we first have to calculate the serum osmolality. Osmolality less than 280 is true hyponatremia. Hypovolemic hyponatremia, low total body water and sodium. In 10% of cases of hyponatremia and cirrhosis, where there will be no ascites or pedal edema and is seen with diuretic use or diarrhea. 90% cases of hyponatremia and cirrhosis will have ascites and pedal edema, and these conditions, CHF or nephrotic syndrome, has to be ruled out. Serum osmolality less than 280 will be two types. Pseudo-hyponatremia, which is seen with hyperlipidemia and hypoproteinemia, and serum osmolality more than 295, which is translocational hyponatremia, which is associated with hyperglycemia and mannitol infusion. Classification, just a few details. Hypervolemic will have clinical signs of ascites, they have anasarca, pedal edema, and the mechanism will be inability to excrete solute-free water, leading to disproportionate water retention. The pathophysiology is increased vasopressin levels, which cause impaired free water excretion. Hypovolemic will not have signs of ascites and edema associated with overuse of diuretics, diarrhea, GI bleed, and fluid loss. Normovolemic is very rare in cirrhosis. The hyponatremia can also be classified according to the duration. Acute hyponatremia, where the duration is less than 48 hours, and chronic, where it's more than 48 hours. In liver cirrhosis, this is mostly chronic hyponatremia, where the brain cells adapt due to exporting electrolytes and organic osmolytes. And advanced cirrhosis have chronic hyponatremia, and they may remain asymptomatic due to this neural adaptation. Hyponatremia due to endocrine disorders, relative adrenal insufficiency, is prevalent in hospitalized critically ill cirrhotic patients, especially with advanced liver disease. 76% in child C cirrhosis and 25% in child B cirrhosis. Around 40% of stable cirrhotic patients may have relative adrenal insufficiency. So in the workup of hyponatremia, it should be a consideration. The mortality with this specific terminology, hepatoadrenal syndrome, is high. Hyponatremia can also be due to endocrine disorders. Hypothyroidism in cirrhosis, mainly the liver is mainly responsible for converting T4 to T3 via the type 1 deiodinase, and advanced cirrhosis affects this conversion due to low plasma proteins like thyroxine binding globulin, transthyretin, and albumin. The mechanism is in hypothyroidism is decreased cardiac output and GFR, which causes impaired water excretion, causing water retention and mild hyponatremia. So the management will be fluid restriction and hormone replacement. Hyponatremia and cirrhosis can also be due to terlipressin use. Terlipressin, which is commonly used in variceal bleeding or hepatorenal syndrome, it is a prodrug that releases vasopressin and acts on V1 as well as V2 receptors. And the V2 receptors in the kidneys leads to water retention. So this is the basic pathophysiology. Cirrhosis, as we all know, leads to portal hypertension, portosystemic collaterals, and breakdown of the intestinal tight junctions. Bacterial overgrowth and translocation, which leads to splanchnic vasodilatation, and decrease in effective arterial blood volume, which again in turn causes activation of RAS, the sympathetic nervous system, and release of ADH, which leads to sodium and water resorption, ascites, and dilutional hyponatremia. This is the key summaries: planchanic vasodilatation leading to decreased effective arterial blood volume and activation of RAS and SNS, resulting in sodium retention, water overload, and dilutional hyponatremia. So the clinical features lead to late stage cirrhosis. Symptom severity will be common symptoms of fatigue, nausea, dizziness, muscle cramps, and gait instability. Neurological features may mimic hepatic encephalopathy, and severe symptoms arise when the sodium is less than 125. Impacts quality of life, and correction will lead to an improved quality of life and modest cognitive improvement. Hyponatremia before liver transplantation also increases the risk of sepsis, longer ICU stays, and poor short-term survival. ACLF and paracentesis-induced circulatory dysfunction are common in advanced cirrhosis with complications. Serum sodium optimization, thus, before transplant is very crucial for better outcomes. It has implications with refractory ascites. 10% of patients with grade 3 ascites require large volume paracentesis despite diuretics. Hyponatremia and refractory ascites, 30% with serum sodium less than 130, and once refractory ascites develops, 1 year survival drops to 30%. Hyponatremia, in a small subset of cirrhotic patients with ascites and hyponatremia, they may develop renal dysfunction. Around 40% of patients with serum sodium less than 130 develop AKI compared to 28% with normal serum sodium levels. And SBP, infections, GI bleed, nephrotoxic medications are the precipitating factors. PPCD after LVP can cause reduction in the effective arterial blood volume, which leads to PPCD, and is characterized by increased hyponatremia, AKI, and worsening HE. So the prevention of PPCD can be important in managing hyponatremia. Albumin infusion with vasoconstrictors have shown success in PPCD prevention. So there are meta-analysis where albumin versus vasoconstrictors and combined albumin with vasoconstrictors have shown efficacy than albumin alone. Midodrine, there are meta-analysis where midodrine has also been shown to be superior to albumin in PPCD prevention. ACLF, which we all know is a very rapidly progressing liver failure in a pre-existing CLD, and the prevalence of hyponatremia in these cases is around 25%, very high mortality, 90-day mortality in hyponatremic patients. Same with liver transplant. That's why MELD sodium has become important for organ allocation. But the drawback of incorporating sodium in MELD is that sodium levels may be influenced by medical interventions, fluid intake, Vaptan use, and thus potentially skewing the MELD sodium calculations. So this is a flowchart on how we manage hyponatremia in cirrhotic patients. So hyponatremia in cirrhosis, first confirm true hyponatremia depending on the serum osmolality, and then with hypervolemic hyponatremia, if the serum sodium is less than 110 with encephalopathy, seizures, and coma, hypertonic saline is the treatment of choice, and 100 ml over 15-30 minutes can be repeated 1 to 2 times till the rise is around 6 millimoles in 6 hours. If this also fails, then these patients will need continuous venous hemofiltration, and if even that fails, liver transplant has to be considered. So serum sodium 110 to 130, this is the scenario which we commonly face. So the first thing would be to stop diuretics, restrict this fluid if serum sodium is less than 120, correct hypokalemia, because hypokalemia correction in turn leads to sodium correction also. Albumin infusion if there's no improvement after 48 hours. Long-term albumin infusion should be considered. Tolvaptan 15 mg per day. We can go up to maximum of 60 milligrams per day for up to 30 days, and even if this fails, then liver transplant should be considered. In hypovolemic patients, we need to stop diuretics, start albumin infusion, also normal saline, and correct the underlying cause. So this is a brief detail on what to do. Patient stratification is important. We have to first identify the type, then the severity and duration. Hypovolemic, as we discussed, stopping diuretics is the main line with administration of fluids. In hypervolemic, when the sodium is less than 120, These rapid correction has to be avoided to avoid osmotic demyelination syndrome. Temporary discontinuation of diuretics is recommended when serum sodium is below 125. Also, discontinuation of beta blockers is important as most of these patients are on variceal bleed prophylaxis. Non-selective beta blockers can worsen the ascites and hyponatremia, and they should be considered when the MAP is less than 80. Some guidelines also suggest less than 70. Continuing non-selective beta blockers can lead to increased mortality in these subset of patients. Role of midodrine and octreotide. As we all discussed, midodrine has to be titrated to maximum 15 milligrams thrice daily, and evidences show even rise from 124 to 130 millimoles in 3 days. Correction of hypokalemia, as we discussed, hypokalemia which causes metabolic alkalosis and worsens encephalopathy. Potassium correction will lead to exchange of potassium into cells, which leads to sodium correction. The important caveat here is to not rapidly correct so that ODS doesn't develop. Albumin infusion, as we all discussed, dose is 1 gram per kg per day, maximum 100 grams until hyponatremia symptoms resolve, but again the limitation becomes high cost and need for compliance in long-term treatment. Hypertonic saline infusion, only when the sodium is less than 110 and there are other symptoms like seizure and altered sensorium. These can be, but overzealous correction should be avoided. Vasopressin receptor antagonists, the problem initially with conivaptan was hypotension, variceal bleed, because these are V2 receptor antagonists. Tolvaptan is a promising drug, but again the limitation is no studies more than 30 days duration, and maximum dose up to 60 milligrams. This was a saltwater trial where patients are followed up for 2 years, and sodium correction was noted in these patients, improved sodium, but the adverse effects, polyuria, thirst, and rare side effects of ODS, AKI, and GI bleed were noted. Water restriction for hypovolemic hyponatremia, as we discussed, around 1 to 1.5 liters per day. Fluid intake should be 500 ml less than the combined insensible losses. The challenges are poor patient compliance due to increased thirst sensation from high ADH, and the efficacy results have shown significant sodium improvement with water have not shown very significant improvement with only water restriction. Tips. Hyponatremia before TIPS increases the risk of hepatic encephalopathy post-procedure. So correcting hyponatremia before TIPS is important for success. Currently, hyponatremia alone is not an indication. ODS, as we all discussed, should be is one of the challenge in sodium correction. And a brief on the pre-op and intra-op and post-op sodium management in liver transplant. Hyponatremia and liver transplant, prolonged hospital stay and neurological complications. Severe hyponatremia may increase 1 year mortality. So the correction approach is again slow, and emergency liver transplant, fluid restriction, diuretic discontinuation, trial of 20% albumin should be given. Perioperative patients, the risk of rapid sodium correction is standard fluids, so half normal saline, 5% dextrose is to be used. CVVH with slow sodium dialysate to prevent sodium shifts, and blood products, cryoprecipitate should be used instead of FFPs. Post-op management, hyponatremia often resolves after cirrhosis correction. Intensive monitoring has to be done in 48 hours, and frequent monitoring for patients multiple transfusions or on CVVH. Future way forward, combined use of vasopressors and volume expanders, albumin, tolvaptan, midodrine, which needs further investigation. Preemptive tips requires more research. Thank you.
Very nice presentation, Dr. Ravi. Are there any questions?
Sir, osmotic demyelination syndrome develops when you correct sodium levels. These patients are having stroke-like features. How will you differentiate?
MRI with hyperintense lesion on T2 weighted images. This is mainly in the pontine and extrapontine areas. I mentioned in this slide, ODS slide.
Is there any other way clinically?
The clinical features will be quadriparesis, seizures, and encephalopathy. Mainly imaging helps differentiate.
One comment I would like to mention regarding the relation between the terlipressin use and the risk of hyponatremia. This is very intriguing. While using the terlipressin for HRS purpose, actually the serum sodium may increase, may improve, but in patient with acute varicose bleed, and while using the terlipressin, the serum sodium level may come down.
Sir, patient came to us with the history of the stroke 1 year back and continuous suffering from the hyponatremia, and hyponatremia level 1 to 100 to 229.
Cirrhotic patient?
No, sir.
Non-cirrhotic?
Stroke. Non-cirrhotic.
Non-cirrhotic?
Non-cirrhotic.
Okay.
And we should
That will be difficult for me to answer. Okay. Fine, you can continue. I'll try.
We should go for the hypertonic solution treatment or not?
See, hypertonic saline infusion restriction, this was specifically for cirrhotic patients because they have dilutional hyponatremia for these cirrhotic subset of patients. For them, the standard indications can be used.
Means patient have the fatty liver grade 2 also?
That will not affect.
That will not affect. Okay, thank you, sir.
Thank you so much, sir. The next speaker for the session is Dr. Ashish Kumar Jha, sir. He'll be showing light on the topic of early gastric cancer diagnosis. Sir is the director of the Institute of Digestive and Hepatobiliary Sciences, Medanta Super Specialty Hospital, Patna. He has an impressive collection of prestigious awards to his credit. He has his name to 109 publications, including 45 international. We welcome you, sir.
Thank you, chairpersons and organizer, for giving me opportunity. In 15 minutes, we will discuss just brief about basically diagnosing is suspicious malignant lesion or early gastric cancer. We all know with use of magnifying endoscopy, especially NBI or FIRES or other system, so the detection of early small lesions and suspicious lesion is increased in day-to-day practice, and we have the treatment of such lesions like EST. It's a commonly done. So detail regarding the EST will be taught by Dr. Bikasana later on. We will just confine to myself to the just approach to diagnosis. So early gastric cancer is invasive carcinoma. By definition, it involves only mucosa and submucosa, irrespective of lymph node status. In Japanese or Korean population, 50% of cases is diagnosed as early gastric cancer because they have the screening programs. But in European country, approximately 20% of newly diagnosed cases are early gastric cancer. In India, we don't have any screening programs or we don't have such data. So if you see the detection of these, most of these lesions are located in body or distal part. And as most of these are detected in screening programs, so age group is obviously more than 56 years old, so 70 year in median age. And majority of these diagnosed cases are smaller, like 20 millimeters in size or depressed, well differentiated type. And with Paris classification, majority of them are the depressed. These are the general demographics of recently published paper from Japan. So we all know the basic about this H. pylori infection, inflammation, chronic atrophic gastritis, metaplasia, dysplasia, then malignant sequences. So how do we approach? So first, when we suspect, the step first is the detection of suspicious lesion. When should we suspect this lesion is a potentially malignant lesion? Then is it a cancerous or non-cancerous? Then is it a well differentiated or undifferentiated? And finally, is it a T1A or T1B? So when we suspect these lesions. So when a mucosal surface structure is different from surrounding with a demarcation line. So in general, chronic gastritis or any kind of gastritis have red lesions, even pale lesions or elevated nodular gastritis. But demarcation line is important. So with demarcation lines, if we find some mucosal irregularity with what is, especially with what is color, or a large nodules, or noticeable red changes, and a size is around more than 2 centimeter, even less than that, so it's likely to be a neoplastic lesion. And then differentiation has to be made regarding is it a fundal gland polyp, hyperplastic polyp, or intestinal metaplasia, or neoplastic lesions, such as adenoma or cancer. So demarcation line is important to differentiate it from malignant from non-malignant condition. So a widely used classification method for any suspicious lesion is Paris classification. So is it a pedunculated lesion or sessile lesion? 1, PS. These are the benign conditions like adenoma and polyp. And 2 onwards, like 2 elevated lesions, 2B flat lesions, 2C is central depression, and 3rd is excavating lesion. And we may find this combination like elevated margins with central depression, or predominantly central depression with a slight hanging margin, elevated margin, or predominantly excavated lesion with elevated margins. So we may have such combinations. Like just a photograph showing some sessile lesions, type 1. Similarly, type 2, 1 flat elevated lesions, and second one is a flat lesion, but we can see this well demarcated red lesions. Third one is the depressed lesion, which is 2C, which is usually neoplastic, and then one combination of elevated, as we can see the central depression, and followed by elevated margins. And finally, type 3 excavated. Majority of these lesions are usually malignant. So when we see this Paris classification is based on the white light in standard endoscopy, so then we can see this narrow band imaging. So in this case, if we see this anatomy of, so we can see the pit and then subepithelial capillary. This is the pit area. So in NBI image, this is the opening of pit opening, then subepithelial capillary, intervening part, collecting vanules, marginal, the cell around keeps marginal epithelium. And this is the surface structure, then vessel structure, we call it as a vessel plus surface structure, and then vessel structure. So subepithelial vessels we can see here, subepithelial vessels around this. So this is a classical basic NBI image of a gastric mucosa. So when we see this suspicious lesion, so this is the standard regular surface pattern and vascular pattern. Here we can see this well demarcated line, and inside this well demarcated line, the surface pattern is irregular. Here is the vessel pattern. If you compare with the left side, so vessel pattern is again irregular, and again we have the well demarcated lesion. Similarly, here surface pattern is totally lost, and vascular pattern is totally messed up or destroyed. So this VS system, we basically we can able to classify when this lesion as a suspicious malignant lesion. So once we have suspicion, then is it a differentiated or undifferentiated? Again, we should go first with a white light endoscopy. If lesion is reddish or isochromatic the same color, then it's likely to be differentiated. If it's a pale color, So it's undifferentiated. Pale color because of vascular disruption, there is hemoglobin, low hemoglobin in this area, that's why pale color. So basically reddish and isochromatic lesions are differentiated type, however this pale color is an undifferentiated type. Then we see the vascular pattern. If vascular pattern, macro surface pattern, irregular part is the classical part pattern is present, and then it's a differentiated type. If its pattern is microvascular pattern, if it's a polygonal, lace pattern or closed loop pattern, so in this case it's a usually differentiated type. However, it's a disrupted vascular pattern or open loop pattern or interrupted vessel pattern. These are different terms are coined for this. So these are the undifferentiated type of patterns. So undifferentiated type usually, if we classify this, so as summarized differentiated versus undifferentiated, so elevated and protruded lesions or flat and depressed lesion with red area are usually differentiated. However, the flat and depressed lesion with white lesion tone is actually undifferentiated, and excavated lesions are undifferentiated. By Paris classification, 1, 2A or 2B are usually differentiated. However, 2A plus 2C or type 3 is undifferentiated, and 2C is basically it can be both differentiated. So 2C is basically borderline gray area. And NBI we can see this honeycomb, fine network, closed network. These are the differentiated. Open loop is cork screw pattern. These are the undifferentiated pattern. So once we classify the differentiated versus differentiated, then we have to see because ESD decision of ESD EMR is also dependent on the submucosal invasion or surgical resection. So that's why we can classify it as a 2A or 1A versus 1B, 1A mucosa, 1B submucosa, because up to 5 micron 5 micron of invasion of submucosa can be resected with ESD, and beyond 500 micron ESD is not indicated, then we have to go for surgical resection. So these are the some features. Based on that, we can differentiate as a 1A or 1B. Like elevated and protruded lesion is less than 2 centimeters, it's likely to be 1A. And elevated lesions with smooth and regular surface and without erosions and redness regardless of size is also usually it's a 1A. However, this is a flat and depressed lesion with deep depressed lesions, surface is harder or nodules of unequal size, and these are indicative of one-way lesion or lesion more than 2 centimeters as actually submucosal invasion. Routinely endoscopic ultrasound is not indicated because it has a low yield for diagnosing this. However, many probe can be used, but again it's not recommended for all evaluation of all the early gastric cancers. If you apply all these parameters, in that case we can have the sensitivity of specificity of 84%, sensitivity of approximately 70%. With the white light endoscopy itself, we can diagnose as with a certainty of 70% sensitivity and 85% specificity. And if NBI you use, so we can differentiate undifferentiated versus differentiated pattern almost more than 90% surety. And histology, finally, histology we can differentiate obviously. So to summarize, if we start with the white light endoscopy, so white light endoscopy, we can see redness or same color. Then we use this NBI, we can use this magnifying. If we have confidence, then no biopsy required. If we have some low level of confidence, then biopsy is indicated. Similarly, in pale color, if we have white light endoscopy, we see pale color lesions, then biopsy is required because pale color lesion can be neoplastic. So biopsy here is required. And another system for using this magnifying endoscopy, magnifying simply diagnostic score. If we have the suspicion lesion, so first identify the demarcation line, and then if demarcation line is present, then we see this irregular vascular surface pattern or vascular pattern. If irregular vascular pattern or surface pattern is there, then it's likely to be cancer. If surface pattern or vascular pattern is not irregular, then it's likely to be non-cancer. Similarly, if demarcation line is not there, though lesion is elevated, though lesion is red or altered color, then it's likely to be non-cancer. So so these lesions can be treated with EMR, like strip biopsy or cap EMR, band EMR, or some ESD. So indications are indications if any lesion less than if surface in ulceration is absent, T1A lesion less than 2 cm, we can go for the EMR or ESD. But for more than 2 cm, even ulcerations is not there, ESD is relatively indicated. And up to 2 cm of size, if surface ulceration is not there, and even if it's undifferentiated, ESD can be done. If ulceration is there, then less than 3 cm of size of lesion is there, then ESD can be done. EMR we cannot done here. And more than 3 cm if ulcerated lesions is there. So actually ESD not done, not usually, but relative indication and it's little tricky. So with this, this is some ESD performed, and this band EMR not done on gastric cases, so I'm just moving on. So overall survival, if we detect it earlier, survival can be 90%. With conclusion, diagnostic yield of gastric cancer, it has significantly improved by the magnifying endoscopy. With NBI newer endoscopes, we have the NBI facility or FICE facility. And ESD can be done if lymph node metastasis is not there, and we can go for the EMR is also effective less than 2 cm, and so we can make a tailor-made decision. Thank you very much.
Thank you, sir, for a very nice and elaborative presentation. I think the detection of this early gastric cancer is often missed. There is a norm that endoscopy has to be done just hurriedly without examining the whole mucosa properly. And addition of this narrowband imaging and image enhanced endoscopy is important. So are there any questions regarding this lecture?
So just continuing on that comment my question is it that we do our endoscopies very hurriedly, that is why we miss early gastric cancers, or is it that the scopes that we use, most of the centers would be having at the most a 190 series of endoscope? Do you think that our scopes are not efficient enough to pick up these small lesions? Because as in Japan, most of them they are using 290 series or other more advanced kind of imaging modalities. Do you think a 190 series scope is good enough to pick up these very small and lesions which require a lot of magnification, a lot of vascular identification? What is the problem? Is it the time, or it is the...
It's all three factors. As I watched in South Korea, actually, first of all, they had very good preparation. They are continuously using this semi-thick-ons other solution for screening endoscopy, number one. And they are giving enough time because they are taking 22 pictures, 12 in forward view and 10 in retroflex view, and they are documenting every image. And at least 7 minutes of inspection, they are routinely following that protocol. So 7 minutes of inspection is the mandatory for screening endoscopy. These three factors are important. Then obviously, if we are using endoscopes 140, 50, since we are using this Olympus model or so. And now, if you see the quality of 190 series versus 140, most of us are using since 140 model. So it's a hell and heaven difference. So all three factors are important. Most important, and most of our patients we are giving less time and a lot of froth are there. We don't bother to repeat that procedures again. So obviously we are missing, and maybe prevalence is not high.
So with the busy practice that most of the people would be having, do you recommend that we should screen patients where you see some risk factors like very elderly people, or you see atrophic gastritis, and then you spend more time in such patients and screen them more efficiently rather than doing this for every person? I am sure it is not possible to spend 20-25 minutes for every person in endoscopy itself.
Majority of us, we don't have time for every patient doing that. So we can actually do this like a high-risk patient more than 56 years old age. As we have said this, if we have some chronic gastritis or some feature of atrophic gastritis, at least we should careful on those subset of patients.
Yeah, Ashish, excellent presentation. I think to to diagnose early gastric cancer, our white light examination should be very good. So patient should be fasting and patient should be prepared with cytotic or N-acetylcysteine. And then if we are doing white light endoscopy, we should not miss any area of erythema, pallor or the erosions. So we see many reports, we report them diffuse erosive gastritis or the erythema of stomach thin. So these can be early gastric cancer. So if you have a high definition endoscope, you go for the high definition endoscopy. So I think Olympus will come up with the 1200 series, and the Fuji already had a BLI scope. They have magnification up to more than 100 times. Our 190 HQ, these have a limited magnification, but with the future 1200 and the BLI, so this will give us a very good high magnification. But I think white light examination, good white light examination, we can suspect and we can take biopsies if we don't have a high definition endoscope. With that, I think we can diagnose a lot of early gastric cancers. And second, my comment is regarding the biopsy. So if you are suspecting early gastric cancer, isn't it mandatory to take a biopsy? Because if it's an undifferentiated cancer, you have to take a circumferential biopsies to define the extent of cancer. Because sometimes there can be submucosal spread of cancer and mucosa may not show the findings.
So actually problem with this biopsy, if you are planning for ESD, then it will create trouble. So if you are certain it's a suspicious lesion anyway you have to remove, so biopsy is not required for all patients.
I think for undifferentiated, there can be, if you are suspecting undifferentiated,
then we can go for.
And maybe you can take a small superficial biopsy, which will not may hamper with the
What I have observed, they are practicing if any lesion is they can remove by the ESD. They are removing the hyperplastic polyps. So for Japanese and Korean, so they are not going for biopsy. But for us, because we are not using so much doing the so much EST and other things, so biopsy should be done. Thank you.
Dr. Assis, nice presentation. Do we have any data comparing normal endoscopy versus AI-assisted endoscopy in diagnosing early gastric cancer?
They are coming up, but I didn't. I have seen a few papers because AI have the better detection of any suspicious lesion. But Dr. Vikas will tell if you have any comment regarding that. There is no definitive data, so we can use this routine AI recommended machine.
I think during your initial part of when you are not well trained, that time AI may be helpful. Once your eyes are trained to detect early lesion, I think it's as good as AI.
Yeah.
Or I think for the initial part of your career, AI may be helpful.
Just as a continuation of comment by Vikas, sir, is there any good quality data which supports that image-enhanced endoscopy is better than good white light endoscopy in detection of early gastric cancer? Or a good quality white light endoscopy is good enough? Because we routinely do not obviously do NBI in every part, only in suspicious cases.
So Japanese are the gold standard, or Korean are the gold standard. They have seen good white light endoscopy up to 80% of time they can diagnose. And if they are adding on this NBI or white, only 10% additional improvement on overall success rate. So up to 70 to 80% is white light, and if they are adding this NBI, so 10% different, I guess. But it was statistically significant in one paper I have shown.
Can I make a comment?
Yes.
So white light is to initially suspect a lesion. You see any raised area, pale area, you suspect it can be malignant. And NBI with magnification, it will confirm the diagnosis. So after the multiple lesion, they can be benign or malignant. So once you have NBI with magnification, if you see a demarcation line, irregular vessel, irregular surface pattern, that nearly confirms the diagnosis. So there are two-step approach. First is the good white light examination, you suspect a lesion, then you confirm with the image-enhanced endoscopy. So white light is must.
So basically, NBI increases specificity. Sensitivity doesn't increase. So even one study I have quoted, the sensitivity was it didn't improve sensitivity, but specificity was improved a lot.
Thank you, sir, for the very nice presentation.
Thank you, sir. So we have our next speaker, Dr. Pranav Kumar Mandal, sir. He'll be throwing light on the topic of rational fluid therapy in acute pancreatitis. Sir is a senior gastroenterologist in the Samford Hospital. We welcome you, sir. I would request Dr. J.K. Mitra sir to please come on the dais for the moderator. Thank you, sir.
Good morning, everybody. My topic is rationale of fluid therapy in acute pancreatitis. As you know, that acute pancreatitis is an inflammatory disease of the pancreas, and the most of the acute pancreatitis mild in severity, around approximately 80% of the pancreatitis mild in severity, whereas 20% of the patients with pancreatitis presents in severe cases. That is the cause of significant mortality and morbidity in the tune of 15 to 20%. So, if you see in the last decade, recent advancement in the management of acute pancreatitis, fluid therapy is one of them. So what is the rationale of fluid therapy in case of acute pancreatitis? Let's discuss in next 10 minutes. So just brief review of the pathogenesis of acute pancreatitis to understand the rationale of fluid therapy in acute pancreatitis. Any insult, either alcohol or passage of gallstones, leads to activation of the pancreatic proteolytic enzymes that leads to local inflammation, leading to autodigestion of pancreatic and peripancreatic tissue that lead to generation of cytokines at local level and systemic level. At local level, it causes cellular dysfunction, and local and systemic microcirculatory dysfunction leading to pancreatic ischemia, vasodilatation, and loss of fluid loss in the retroperitoneal compartment. In mild pancreatitis, approximately 4 liters of fluid lost. In severe pancreatitis, 6 liters or more than that fluid of that lost. At the systemic level, there is a massive release of cytokines that is the cause of systemic inflammatory response syndrome and multi-organ dysfunction. So, in the genesis of acute pancreatitis, two factor importance. One is the role of cytokines. As you know, in the body there is a pro-inflammatory response and anti-inflammatory response. When there is a pro-inflammatory response and anti-inflammatory response in balanced manner, pancreatitis terminates in a mild manner, and most of the cases are mild pancreatitis. If there is a massive release of pro-inflammatory cytokines and there is a less anti-inflammatory response, that leads to severe pancreatitis, and that leads to systemic inflammatory response syndrome and multi-organ dysfunction. So in the late 90s, people thought that as in IBD, if we block the tumor necrosis factor, we can terminate the disease cascade or control the disease cascade. In that thought, in late 90s, the many pilot studies and small randomized controlled trials come that in those all trials, they targeted the proteases with anti-proteases, various receptor blockers, tumor necrosis factor blockers, but all those trials were negative. So nothing left, not a single drug can block the cascade of acute pancreatitis. So what left with us? So pancreatic microcirculation. As I told that hypovolemia is one of the important factors in the pathogenesis of acute pancreatitis. So if you look at the pancreatitis pathogenesis, see that the two spectra, edematous pancreatitis and necrotizing pancreatitis. And there are various factors including hypovolemia, that is the main culprit, that leads to inflammatory cascades, release of cytokines, that increases capillary permeability, increased coagulability, vasoconstriction, leading to pancreatic macrocirculation disturbance, leads to pancreatic ischemia, and that is the major cause of systemic inflammatory response syndrome and multi-organ dysfunction. If you block this cascade by correcting hypovolemia at the early stage, you can prevent this conversion of edematous pancreatitis to necrotizing pancreatitis, and most of the mortality and morbidity can be prevented. So, in the recent advancement of the pancreatitis, what fluid therapy? In resuscitation of pancreatitis, issues comes when to start fluids, what is the optimal fluid, is there a role for colloid, what is the target for fluid therapy? Coming to this slide is very important. As you see in this slide, with the onset of pain, there is a cytokines generation, and organ failure develops gradually over a period of 0 to 36 hours. So this is very important. The role of fluid therapy comes in the early course of acute pancreatitis, and this therapeutic window is very important. So in this early studies, people have demonstrated that if you correct early hypovolemia, in this retrospective trial, they have demonstrated that the patient develops necrosis, those in whom there is no rapid correction of hematocrit. If you correct hematocrit by adequate fluid resuscitation, most of the patient of the pancreatitis resolves, and those are mild pancreatitis. And the necrosis group, they have seen there was no significant drop in hematocrit, which is the marker of fluid deficit, at 24 hours. So inadequate fluid resuscitation associated with increased necrosis and increased mortality and morbidity. So what is the optimal timing and rate of fluid administration? This is the early studies in 2008 and 9, the Gardner's group. In the first retrospective trial, they have shown that if you do early resuscitation, that is more than 33% of fluid administered in 24 hours, the chances of mortality, persistent organ failure, hospital stay less in comparison in which group of patients in those late resuscitation started in the first 72 hours. Similar prospective study, similar group have done, and they compared aggressive fluid therapy versus non-aggressive. Again, they found that organ failure, hospital stay, and ICU stay was less in the aggressive group. But later studies came, and the many criticism, the patient in group with aggressive fluid therapy, the adverse effect was fluid overload and acute lung injury. So there are lots of criticism. To answer this question, Chinese group conducted 2 RCTs on patients with severe acute pancreatitis, aggressive versus conservative strategy. In the first study, a group received a fixed fluid rate of 10 to 15 ml per kg per hour, while the second group received 5 to 10 ml per kg per hour as needed to achieve hemodynamic stability. In the second trial, a group received IV fluid at admission, rapidly aiming at a hematocrit correction less than 35%, while the other groups had a hematocrit target more than 35%. In both studies, the author reports a higher incidence of sepsis, higher complication due to fluid overload, and a higher mortality rate when fluid was administered in a high volume. So, what is the current recommendation? Till date, there is no guidelines, but there are recent evidence and expert opinions suggest starting fluid rate should be 5 to 10 ml per kg per hour for the first 24 hours. Suggested goal, these are the clinical goals, heart rate should be less than 100 beat per minute. Mean arterial pressure should be more than 65 mmHg, urine output should be more than 0.5 ml per kg per hour, and hematocrit in between 35 to 44%. So after the early critical phase, you have to analyze patients hourly or 2 hourly, 3 hourly. After this early critical phase, fluid rate is usually reduced to 2 to 3 ml per kg per hour. So what is the type of IV fluids? Crystalloid versus colloids. Colloids, they have many trials with hydroxyethyl starch. All trials were negative. So crystalloid is the fluid of choice. Normal saline versus ringer selected. There are 5 or 6 randomized controlled trials which suggest ringers lactate, means lactated ringers, a highly hypotonic, slightly hypotonic, balanced crystalloid has been compared to NaCl 0.9%. Patient randomized to RL had a reduced prevalence of systemic inflammatory response syndrome, a lower concentration of C-reactive protein at 24-hour post-admission, and similar results were described by other authors. Which fluid? This crystallized the preferred fluid. American guidelines also recommend that ringers lactate is the preferred one. The role of colloids is very limited. When the patient presents with anemia and hematocrit is less than 25%, there is role of blood transfusion. Role of albumin transfusion again limited if the patient presents with very low albumin, less than 2 gram per dl, then only. Now, what are the clinical endpoints? And heart rate less than 100 per minute, a mean arterial pressure between 65 to 85 mmHg, urine output more than 0.5 ml per kg per hour are desired endpoints in the management of severe acute pancreatitis. Lactate levels and central venous saturation are indirect marker of organ perfusion and tissue or the oxygen delivery. Hematocrit and BUN. Hematocrit is the best marker because BUN is influenced by the acute kidney injury, and most of our severe acute pancreatitis initially presents with either perineal azotemia or AKI. So hematocrit is the best out of hematocrit and BUN. So what are the take-home messages? Severity assessment is must. As we know, the revised Atlanta classification is very important, and in revised Atlanta classification, this is the bedside assessment. First, you have to define whether the presentation is less than 7 days, means early presentation, or late presentation, because the role of fluid therapy comes in the early 7 days of the acute pancreatitis. Severity correlates with outcome. According to modified Atlanta classification, severity classification is very easy. That is defined by circulatory disturbance. If the patient present with hypotension, that is BP is less than 100/60, we classify this as severe. If there is an acute kidney injury in the form of rising creatinine, decreasing urine output, you define as the acute kidney injury. If there is an oxygen requirement or ALI in your APG calculation, it's a respiratory failure. Any one of them if present, you classify this as severe acute pancreatitis. If it resolves within 48 hours, that you classify as moderate to severe. If it doesn't resolve within 48 hours, it's severe pancreatitis. Crucial timing is 24 to 72 hours. As you know, there is no single drug which can reverse the cascade of acute pancreatitis. The mainstay of therapy is supportive care, and among the supportive therapy, judicious and early fluid replacement is the choice, and crystalloids in particular, RL is the fluid of choice. Thank you.
So thank you, Dr. Pranab. First of all, I must congratulate you for sticking to your time and you can finish your talk just in time later. It was a very important topic. Many times you will see that acute pancreatitis is overdiagnosed or underdiagnosed. And the management portion is very important. So you have highlighted the main point of the treatment very well. I don't think there should be any question regarding this, but if there is any comment or any question from the audience or from our moderators, please.
Actually, acute pancreatitis rise in our area also due to prevalence of alcoholism. In RIMS, we see 2 to 3 cases per day per emergency, mainly due to alcoholism, or some cases due to this gallstone disease. So, as you suggested, fluid therapy is the mainstay. After this, octreotides, antibiotics, injections, and prokinetics, etc.
So, if the patient of pancreatitis presents early, there is no role of either octreotide or antibiotic. If the patient presents late, then that's just.
I must highlight one point also that the acute pancreatitis is overdiagnosed or underdiagnosed, and that is very important all the time. I think so. I don't know whether you are. What is your comment regarding this?
No, so it's a very straightforward diagnosis. If the patient presents with typical clinical pictures, pain in the epigastric radiating to back, repeated vomiting, and raised mileage and lipase 5 times than the normal, then diagnosis is straightforward. So imaging also suggests ultrasound. In the early stage, ultrasound may miss, but my comment is that don't go for early contrast enhanced CT scan, because the most of the patients presents with hypovolemia and pre-renal legitimia. If you do early CT scan, these patients land up with acute renal failure because of contrast-induced nephropathy. So don't do first of clinical and your enzymes are suggested, then it's acute pancreatitis. Treat professional diagnosis of acute pancreatitis. If there is diagnostic dilemma remains after your fluid therapy of 48 hours, then go for CT scan.
Many times there is confusion to the treating physician or treating doctor as well, or surgeon. What about the oral fluid? How much oral fluid they should allow? So that becomes sometimes very difficult for them to decide.
No, as soon the patient is pain-free and nausea and vomiting subsides, you start enteral nutrition as soon as possible, because it prevents translocation of bacteria.
Sir, I have one question, sir. Yes, sir. Sir. The first one is that as serum lipase and amylase, if it is more than 3 times with pancreatic type pain, so is there any role of repeating this serum lipase and amylase every 48 hours?
No, there is no role. But if you are planning for in the same admission, cholecystectomy, surgeons most of them ask that amylase and lipase should be in the normal limit and imaging doesn't show any significant inflammation. So that is the one indications that you do. Surgeons wait till amylase and lipase normalizes.
And another is, sir, in mild acute pancreatitis, if you have to start oral feeding, is it liquid or semi-solid, or both are equal?
You first starts with liquid, then gradually go for the semi-solid, if the tolerance is there.
In those group of patients, how will you manage, what's your advice regarding the fluid therapy?
Yes, this is a very difficult scenario. In the tertiary care center, most of the times we get patient in the late stage, not in early stage. So the talk is basically means our aim is to educate physicians, our physicians and surgeons who receive these patients in an early stage of pancreatitis to prevent significant mortality and morbidity. In our cases in tertiary care centers, you have to be very judicious in fluid therapy. You don't go rush to give the fluid in 10 to 15 ml per. You have to assess either by your ICU ultrasound, you do ultrasound bed, so if there's a CVP monitoring and if that IVC is collapsed, accordingly you give fluid therapy and hourly monitoring of the urine output, BP, mean arterial pressure. So in that particular case, it's a very tricky situation where the most of the patients with renal failure or pre-renal agitemia, what we receive.
Yeah. I think IVC diameter and IVC collapsibility is very important. In fact, more important than CVP to assess the fluid therapy requirement. And another question is, where is the place of CT scan? Does CT scan required in every patient to require to assess severity or in special group?
When there is a diagnostic dilemma, then only you do CT scan. The most of the times confusion is your amylase lipase is marginally elevated, if there is pain and you are suspecting sometimes perforation is the one strong differential diagnosis. In that case you go for the early CT, otherwise not. Diagnosis.
Important thing when patient asks us about prognosis. So CT scan is one thing is scientific, another thing we have to be confirmed 100% sure to be we are dealing with pancreatitis and what is the at least the scope. So when patient asks us is it curable or kind of, these are the important things.
Yes, you just wait for the 3 to 7 days to do CT scan because the most of the complication develops after 7 days. So just to tell the patient what is the severity, that is the Balthazar scoring system. That usually applies to the late presentation of the pancreas. When patient already developed fluid collection or walled up necrosis, those patients are very important. CT scan is very important, but certain type, not in early pancreatitis. My message was that don't rush for CT scan early 48 to 72 hours. That will end up with the contrast-induced nephropathy.
That might even in late, unless the finding of CT changes the management course, the CT should not be done.
Yes. If your patient is having persistent, that is totally your decision, clinical judgment. If the patient is having persistent fever and if you are finding lump or collections, you are suspecting ultrasound, you are planning for drainage, then CT is the must.
CT should not be done only to assess the severity of pancreatitis. This is only what I want to say.
Sir, question. So, two clinical scenarios just recently which I faced. One was this patient was middle-aged, obese female with acute pancreatitis. She was initially having very high RT aspirate and also symptoms of pancreatitis, but then on day 4 I placed nasojejunal freca, triple lumen freca. We could start the nasojejunal feed, but her RT aspirate always was around 1500, 1500, 1200 like that. She was also on prokinetics, everything. The nasojejunal feeds were continuing, but the RT aspirate was not decreasing. CT was done twice, one on day 4, other one later on. Day 4 CT did not show any necrosis in the gland, but there was edema and mesenteric inflammation, peripancreatic outstanding. In these kind of cases, where the patient is also now abdomen is okay and bowel sounds are also there, on prokinetics also, but the RT aspirate is still high. How long should we continue the nasojejunal feeds and wait and not take out the freca? Because that is also more than 7 days if you keep the triple lumen tube there. That is also discomforting for the patient. So ultimately what to do? And then the finances also come in. So what to do in these kind of cases? Whether to send home on the freca or remove it and give a trial of oral feed, how to do it?
You have placed nasogastric or nasojejunal?
Nasojejunal.
So you can send up with the nasojejunal tube home patient. If there is no fever, no tachycardia, and the patient is stable enough, and if the patient is not, simultaneously you have to try, even if the nasojejunal tube in situ, simultaneously you try for the oral feeding. If the patient is not tolerating, you may send the patients home. Many patients comes from even Hyderabad, Delhi with this nasojejunal tubes.
Okay, so we can place it and then send home and remove the continuous aspiration. The RT aspiration, we can remove the RT aspiration.
You can remove, you can remove the RT.
Okay.
But continue with the nasojejunal.
Okay. So second patient, this was a small retained CBD stone, size around 8 millimeter. But I should not have done a small sphincteroplasty, but I did a small sphincteroplasty, small cut and a small sphincteroplasty. Patient was okay post-op, no pain. I repeated the amylase also, everything was okay, 48, 50. Patient went home. After 3 to 4 days, she had continued vomiting. I again did the amylase, again it was normal. On day 4, I did a CT. I first did an endoscopy, there was a lot of fluid in the stomach. Patient was complaining of repeated vomiting. No pain, no SIRS, no tachycardia. Patient had significant fluid. I did a CT. CT was showing some inflammation in the pancreas, pancreatic head inflammation. And then I admitted the patient. So these kind of patients for post-ERCP pancreatitis, how to exactly judge and how long to again hospitalize the patient, start feeding and everything, because the only complaint was vomiting.
First thing, you have to suspect post-ERCP pancreatitis when your procedure is getting difficult. You have cannulated pancreatic duct
In this case, there was no pancreatic duct cannulation.
Yes.
There was a straightforward cannulation, small cut, small sphincter.
Sometimes due to the that papillary edema, pancreatic duct get blocked, orifice get blocked, and you may get this type of cases with acute pancreatitis. And this subset of group of patient, even if not severe pancreatitis, but this is called group pancreatitis. If the head is edematous, that compresses that C loop of the duodenum, and this patient presents with this kind of picture, like repeated vomiting. And it takes 7 to 14 days to subside. In this particular case, you can put nasojejunal tube.
Again as nasojejunal.
Yeah.
Thank you, sir.
So thank you. It was a very interesting session in that way. And I will now hand over the mic to the
Thank you.
Thank you so much, sir. I would request Dr. Syed Altamash, sir, to please come on the dais with the chairperson. So our next speaker is Dr. Sangeet Saurav, sir. He shall be throwing light on the topic of recent updates in the management of acute pancreatitis. An alumni from RIMS Ranchi, he has completed his DM gastroenterology from the prestigious KEM Hospital in Mumbai and is currently a practicing gastroenterologist in Medanta, Ranchi. We welcome you, sir.
So, thank you organizers and the chairpersons for giving me the opportunity. I will be talking on acute pancreatitis regarding updates on management and what is the role of minimally invasive interventions with particular reference to our endoscopic interventions. So, pancreatitis, if I say it is one of the most devastating and troublesome diseases to a clinician or patient, it won't be an understatement. This is among those diseases whose incidence is rising, probably because of increased gallstones and increased alcohol consumption, and we still do not have a specific treatment per se. So when diagnosing a patient of pancreatitis, we must stick to the modified Atlanta classification, whereby a typical pain consistent with acute pancreatitis along with elevated amylase lipase more than 3 times upper limit of normal and or imaging consistent with diagnosis of pancreatitis is important. So as discussed previously also, a CT per se is not required for diagnosis, but whenever we are in doubt that this can be something else, for example, a perforation mimicking as pancreatitis because of elevated amylase lipase, we must do an imaging. Otherwise, an ultrasound actually may be more beneficial in picking up small GB stones. Now, again, a very important point is that elevated amylase lipase as such is not synonymous with pancreatitis. We must know that it has got only diagnostic value. the degree of elevation does not correlate with the severity of pancreatitis, and per se serial estimation of these enzymes are not helpful, which is commonly done in clinical practice, and CT per se is not required, as we have already discussed. Regarding etiology, we know the two main causes are gallstones and alcohol. Post-ERCP, post-traumatic, idiopathic and miscellaneous are other causes. We must understand that when we talk about pancreatitis nowadays, the degree of severity of pancreatitis per se depends upon organ failure. It is quite common that the degree of necrosis would correlate with the severity of pancreatitis, but it is possible that a patient with interstitial pancreatitis with minimal necrosis on imaging may have severe pancreatitis because of severe SUS response. So the severity of pancreatitis per se depends upon organ failure, which is done on ICUs or inwards based on this modified muscle scoring system. There are many indices of severity of pancreatitis. One of those is biceps score. We know we have traditionally many scores available like the Apache and Ranson score, but they are hardly clinically useful. Like they give the criteria for severity in 48 to 72 hours, and I think most of us by that time would already know that this patient is having severe acute pancreatitis. So one of the studies which was published in 2015, a simple study whereby a hematocrit at admission which is more than 44% and rise in blood urea nitrogen for subsequent 24 hours predicted organ failure, and we know that organ failure is something which determines the severity of pancreatitis. So a very simple study where hematocrit at admission and rise in blood urea nitrogen for the subsequent 24 hours predicted severity of our pancreatitis. Coming to management, the management outline is basically first week and beyond. First 3 days is critical because it's the time when we have to decide whether this patient may land up in severe pancreatitis. A patient having severe SUS or organ failure lasting for more than 48 hours is the patient who should be referred to a higher center for better management. Regarding fluid therapy, it has already been discussed, but just one slide that initial management nowadays advocates moderately aggressive fluid resuscitation, not too overt resuscitation of fluid. Patients who are hypovolemic 10 ml per kg of bolus, otherwise not, and all patients will receive 1.5 ml per kg per hour as per the recent ACG guidelines. So this was the study supporting this fluid resuscitation, that early aggressive fluid resuscitation result in higher incidence of fluid overload without improved clinical outcomes. So too much fluid is not beneficial. It may lead to actually more of lung injury and compartment syndromes. Now, one of the important referrals to a gastroenterologist is when should ERCP be performed in a patient with acute pancreatitis. Just to elaborate this, I have 2 case scenarios where we have a patient with a similar demographic profile and bilirubin almost 3.5 and SGPT more than 400 and SGOT around 250 at clinical presentation. Both these patients have got similar kind of SUS response. However, when we follow this patient after 48 hours, we see that although leukocytosis is present in both the cases, the bilirubin in first case has declined. On the other hand, bilirubin on the second case is rising with still raised SGPT, SGOT. Both the patients have pain and high-grade fever. So this is the case where in first patient, actually conservative treatment has to be followed and urgent ERCP is not indicated. On the other hand, the case 2 is a case where the patient is having cholangitis and urgent ERCP is indicated. In such cases where we have a suspected CBD stone is stuck in the lower end of CBD, endoscopic ultrasound is a better modality as compared to MRCP. In this case, an EUS was done which showed a small CBD stones in the terminal CBD and which was later extracted with ERCP. So as per the latest ACG guidelines, acute pancreatitis without cholangitis, ERCP is not recommended, and with cholangitis, early ERCP within 24 hours is recommended. US, a very good modality for as sensitivity and specificity of almost 98% for CBD stones, and actually it is more sensitive for MRCP for distal CBD stones. This is the image of the US machine available with us in our department, and we are doing it. Acute pancreatitis, antibiotics per se, prophylactic antibiotics, just a statement that it should not be routinely used. As such, the infections in acute pancreatitis develop usually after 7 to 10 days, and that is the time when appropriate therapy with antibiotic is indicated. Oral feeding already discussed in previous, but enteral tube feeding should be the primary way of therapy, and TPN should be rarely used. And once the patient has moderate or severe pancreatitis, the patient has entered into the second and third week. The major concerns with these patients are persistent organ failure, and this is the time the patient has high mortality. 50% of deaths occur in the first 2 weeks, and ICU care becomes important. Nutrition is very important in such patients, and this is the time when the patients start developing pancreatic necrosis, and a clinician or gastroenterologist has to make out whether this collection is an infected pancreatic necrosis or not. And in general, so there has been a debate since long whether a patient is admitted to us on day 10 or day 14 of pancreatitis, the patient is having large peripancreatic collection, be it is a pseudocyst or wall of necrosis, developing wall of necrosis. We know that before 3 or 4 weeks, actually we cannot label it as wall. So there has been debate whether there should be an early drainage or a postponed drainage. So this was evaluated in this study recently published in 2021. The trial actually did not show any superiority of early intervention as with respect to postponed intervention. And in fact, in those patients who received early interventions, there were more interventions and more prolonged hospital stay. So this was published in NEGM 2021. As far as management of complications, these are more or less the same which we have been being taught since our medical school. And in newer guidelines, a neostigmine at times can be helpful in IDS, complicating acute pancreatitis. So in management in second and third week, it is a period of maximum waiting, maximum ICU support. Conservative treatment is the norm, nutrition is the key, and if the patient is deteriorating, that is when we should consider drainage of these collections. So infected necrotic collection, postponed drainage is the norm. Necrosectomy can be done either surgically, endoscopically, or minimally invasive surgery. So to address these regarding surgical versus endoscopic drainage, we had 2 trials, the tension and the Miser trial, where they compared the endoscopic step-up approach versus the surgical step-up approach for the drainage of infected peripancreatic collections. And in both these trials, actually, there was no difference in mortality outcomes per se at 6 months of follow-up. But when the subset analysis was done, it was shown that the endoscopic drainage of peripancreatic collections had lesser pancreatic fistula formation and lesser hospital stay. And these 2 studies advocated that a shift towards endoscopic drainage of collection is what should be the norm. However, we should understand that the 2 modalities are comparable, and it depends upon the expertise which is available at the particular center. If the patient can be referred to a particular higher center, that's the best way out. However, if we have a better expertise available with the surgical team, probably they should take over. When the 2 are equal, endoscopic therapy is probably what scores over. So at the end, I would just briefly mention some of my own cases. Like this is a case of pancreatic pseudocyst, which we drained with the indications of drainage of a pseudocyst are those which are symptomatic, infected, causing weight loss or hampering nutrition. Endoscopic drainage is nowadays the standard of care, and pigtail stent insertion, in this case it was done with an ERCP scope. Nowadays we do with an endoscopic ultrasound scope. And this is the post endoscopic drainage picture the very next day. The pseudocyst endoscopically managed. Case 2 is a case of 40-year-old gentleman presenting to us with acute pancreatitis. After initial 2 weeks of discharge, had severe breathlessness, massive pleural effusion, and this was a case of pancreatic to pleural fistula leading to recurrent pancreatic pleural effusion. In this case, an ERCP was done with the stenting of the pancreatic duct because there was a
leak from the distal end of the pancreatic duct, and this resolved with in the next 10 days or so. The case 3 is a case of biliary pancreatitis, moderately severe pancreatitis. After initial discharge from the hospital, the patient came to us with pain, fever, tachycardia and leukocytosis, and there was a ward of necrosis which was there as evident in this CT. There was a large peripancreatic collection here. We should understand that CT at times may not be the best modality to see the degree of necrosis, and it cannot differentiate per se between a necrotic and a fluid collection. In this case, it was a ward of necrosis which was drained with the help of a lumen imposing metal stent. So these are the stents which are available to an endoscopist nowadays, which have coaxial force, and they can oppose the two cavities. And hot axios stent is what is available to us as a lumen opposing stent. And this is one of my own cases which we did few days back, where we could drain this large wall of necrosis with the deployment of an hot axios stent. This is the US image where the stent is being deployed, the inner flange being deployed inside the wall of necrosis, and the endoscopic image of the same patient with the inner flange in the gastric side. At times, in such patients, direct endoscopic necrosectomy is what is needed. After initial drainage of fluid, often there is clogging of the necrotic material at the outlet, and we have to perform multiple sessions of endoscopic necrosectomy, which can be done with an upper GI scope. And these patients required 3 to 4 sessions in a mean time, and lead to resolution of the. Sometimes we can do a percutaneous endoscopic necrosectomy, which can be later stepped up. Other approaches which are mainly done by surgeons are MARPN, SPRPN, and laparoscopic approaches. Thank you.
Thank you, Dr. Saurabh. First of all, I would like to congratulate you for such a nice derivation and elaborative talk and clinical oriented. And today I must admit that today is a very lucky day and matter of pride for me that you are being taught by your student. I learned so many things by Dr. Sangeet. So some comment from my chairperson.
Good morning all. Actually, we work as a team. There I want to tell that there was a case. His pancreatitis was not resolving at all. And we consulted Dr. Sangeet. He said we should go for endoscopic ultrasound. And endoscopic ultrasound was performed, and it revealed 2 mm of CBD stone. And after that we traveled, patient recovered the next day, and he discharged the patient on 3rd day. So endoscopic ultrasound is the better modality. In fact, it's the best modality. We should go in where we suspect CBD stones.
So we have many esteemed US pioneers here, but in our city actually there is limited availability of endoscopic ultrasound per se right now, and we have started doing this, and we know that there are multiple indications and immense potential of this modality.
So can I make a comment? So my comment is regarding early versus delayed drainage. So most of us preferred delayed drainage, but sometime early in the course patient developing rapid organ failure. So till week 2 you want to wait, but sometime at day 15, 16 patient is rapidly worsening, developing hypotension, respiratory failure, renal failure. I think that time you have to intervene. Otherwise patient will not survive the period of 4 weeks. And regarding mode of drainage, we have either percutaneous or the endoscopic. I think during early in the course, we prefer percutaneous drainage. Most of these patients, they have collection which is in the rectogastric area and in the that is extending to the left paracollicular. So it's rare to have a patient with isolated collection in the gastric bed and without any extension into the paracollicular. So early in the course, when patient is sick, I think the better modality can be placing a multiple percutaneous catheter. And we are not worried also about the pancreatic fistula. So we have various techniques now. We can internalize the pancreatic fistula. Late in the course, when patient is stable, no organ failure, just having sepsis with a well-defined collection in the retrogastric area, that time you can do the EUS guided drainage.
Yes, sir. And I think, sir, it depends upon the clinical profile of the patient. Delayed drainage is only for those patients who can be managed conservatively. If the patient is not improving, we have to intervene early, number one. And number two, if the patient is maybe in 12 days or 14 days, obviously we do not have a collection which has a good formed wall. And in that case, endoscopic intervention obviously is not there. We have to go for percutaneous intervention, which can be later stepped up as needed.
Yeah, sometimes we are forced to drain early actually between 14 to 20.
Definitely. And if the patient is not improving, we have to intervene early.
Yeah, regarding choice between MRCP and EUS, I think they are nearly equivalent to pick up a stone. But yes, in the setting of acute pancreatitis, where the small stone size can be small, that stone can be missed by MRCP. Otherwise, in a patient with cholecystitis, deranged LFT without pancreatitis, EUS and MRCP are nearly equivalent. So if MRCP, and the patient prefers actually MRCP. So if you ask surgeon or the patient, they will always prefer MRCP over the EUS.
So regarding distal very small stones, I think EUS might be better than MRCP.
So if you have a patient with the cholecystitis and the bilirubin is 4 or 5 and something directed CP, you will pick up a stone on the MRCP. So actually, if you tell a surgeon that EUS is better than MRCP, but they are still comfortable doing MRCP. For patient, getting an endoscopy done is always a cumbersome situation. They need sedation, they have to come to hospital. MRCP can be done anywhere.
Yes.
So good quality MRCP, I think, is as good as EUS. Until unless you snap in very small stone. So that time you can do a EUS.
Sir, my question is regarding the choice of stent in the wall of necrosis. You used in one patient plastic stent, in another patient I think coaxial stent. So if the patient having wall of necrosis and if cost is the constraint, so whether we can use multiple plastic stents or you want to use like Nagi stent or
Yes. So I think it depends upon the type of the collection, the degree of necrotic material inside the collection, and second, obviously the economic profile of the patient becomes important to us when we are treating such patient. There are multiple stents available. As far as the necrotic collection is there, these metallic stents will be better because many times we would need a step-up approach in the form of necrosectomy, which is not possible with plastic stents. Then you have to remove the plastic stent, dilate the tract, and go do about. If you sum up the whole cost, ultimately it will be the same because you have multiple interventions. Once you have made a good cystogastrostomy via endoscopically by placing a stent, this further procedure of necrosectomy becomes much easier. For example, in this stent, there is a diameter of 1 centimeter or 2 centimeter. If we have put a 2 centimeter stent, the hole is big enough for us to go in and do repeated necrosectomy, which is not possible with smaller caliber stents or a plastic stent per se. So pseudocyst, obviously, I think plastic stent is as good and it is much less cheaper, but when necrotic collection is there, I think metallic stents should be used. Plastic stents, because multiple interventions will be needed, and we know these are interventions which carry a lot of complications also. When you are going in again and again and dilating the tract, there is risk of bleeding and perforation, which we should always understand.
Dr. Sangeet, nice presentation. Thank you. I'd like to make a comment about the step-up approach that combines Dr. Vikas Singhala's comment. Early in the course, you should have percutaneous, and with time, as the wall matures and all the necrosis, whatever sets in, you go ahead with endoscopy. So a step-up approach would be the best one.
Yes, sir.
Sangeet sir, there is a question for you here. Dr. Mayank Shekhar, surgical gastro. So you showed us the video of wall of necrosis treated by endoscopic means. So in the endoscopic means, you need multiple sessions. Multiple sessions to treat the case.
Multiple sessions will be required if we have to go do necrosectomy.
Yeah, do necrosectomy,
yes.
Not in a pseudocyst case, in a wall of necrosis. So do you think that laparoscopic method will be equivalent for those patients, or a robotic method where we have minimal access and we can take out all the necrosome chunk in a single setting? And so, because as a surgical gastro, when we do a cystogastrostomy, it should be minimum 2 inches, 5 centimeter or more than 5 centimeter. So wider margin will give you a wider space to do out the necrosectomy, number one. Number two, we have got the methods like we can operate intragastric. We don't have to put a big incision over the anterior layer of the stomach. We can put the scopes inside this. We can have a dual method. You are putting a endoscope and dilating the stomach. I am putting a laparoscope and putting all the trocars inside the stomach, and then going on the posterior layer, incising it, doing a well necrosectomy, and then coming out, and the stomach will have only 2 or 3 holes for that. Not even an anterior layer has been dissected. So that dual method will make the patient in a single sitting. That will be more cost effective, I think.
So first of all, we should understand that that nature of the collection is important. Those collections which are accessible by endoscopy only, we are trying to drain by US or what. Those collections which are remote from our reach is obviously drained by this step-up approach. And regarding the discussion, so that was the slide that those trials show. So there is no difference in as such major outcome in form of mortality or something. But when we are talking about this fistula length of hospital admission per se, there is a trend towards better management with endoscopic approaches. And we should understand that the both modalities are complementary. And once we have created this kind of access to the cavity, the further interventions are necrosectomy, which is either being done by you through a percutaneous route or by us through a cystogastrostomy route. And this necrosectomy is ultimately like debriding the necrotic material from inside and flushing the cavity. Sometimes we even put a nasocystic drain, which is very helpful. For after initial drainage, we put a drain which goes via nose and into the cavity, and multiple sessions of because we know you must have also seen that in initial stages of this necrosectomy, it is very hard, difficult to take out these materials.
It's better to delay the case as much as possible so that the necrosome becomes fluid.
So in that case, we have a very simple intervention like putting a nasocystic drain and flushing the cavity, which really helps.
I ask this question because I am using both the endoscopy and the laparoscopic method both. So when I do with endoscopy, it makes me feel very hard. It is very technically demanding, and the part of the necrosome are very small. But when I do the same case with laparoscopy, the suction which we take, it takes out all the things, and we can get it more easily.
Regarding suction, what I want to make is these cavities are really like challenging ones. When you enter this, I have experience of with 2 or 3 cases only, but there is a risk of bleeding. You are always very worried about flushing, and you are talking about applying suction. I am more worried about bleeding. If it happens, it can be difficult to manage. So, and obviously it depends upon the expertise which is available to the center. Dr. Vikas sir, if you can make any comment.
So, I agree with you. So if we have both the options, surgery and the endoscopy, they are equivalent. So if the patient is clinically stable, only having sepsis, and you can very well go with the surgery and do the drainage. And especially the patient has gallbladder in situ. So you can tackle with one surgery gallbladder and the infected collection. But the problem is that we have limited surgical expertise. Now we have a lot of gastroenterologists who are doing endoscopic intervention, but very few surgeons who are doing pancreatic work in the case of acute pancreatitis. So if expertise is available, so if at your center you don't have any gastroenterologist and you are the surgeon, you can very well go inside, do the cystogastrostomy, do the debridement, removing gallbladder at the same setting. And then regarding necrosome, there are 2 types of necrosome. One is the white tissue and one is the brown tissue. So whenever there is a white tissue, it's a fat only, surrounding fat. It is easy to remove by any means, endoscopic, percutaneous surgery. When you have a red tissue which is very elastic, it has deep adhesion and it's a necrotic pancreatic tissue. That tissue bothers us. Brown tissue is difficult to remove by endoscopy, and there is high risk of bleeding when we are removing the brownish tissue. Have you seen that brownish and?
I have got my slides where I have done endoscopic necrosectomy in a patient. Actually, he had a index surgery for cystogastrostomy, open surgery, and he was well to with that surgery. He joined his work, and again he had an attack of pancreatitis. And when we do the CT, there was a lot of gas in the CT. So I could understand that is an infected pancreatic necrosis. So I went with the side view endoscope. I found out the tract, put a guide wire in it, dilated the tract with a CRE balloon, and went inside and toward the necrosectomy with endoscopic method.
Yeah.
So when I did with that method, it was very challenging for me to handle that long scopes. And when we do with classical laparoscopic method, it becomes more easier.
Yeah, so but we are doing at our center, we are routinely doing endoscopic nephrectomy. So I think with the experience you can learn that, and you can.
I was lucky enough that I have to do only one session.
Exactly, it's same. Now it's enough of discussion, I think. So we should leave it now. It's all about expertise. That's all.